طيب. Good afternoon. Are the slides clear?
Yes, clear.
Yeah, clear.
Okay, so today, inshallah, this is the first topic of today's topics. We'll be talking about conduit choice and latency in Cabbage. The way this presentation is structured, I'm not going to be talking about, mostly I'm not going to be talking about individual conduit, but rather some concepts and conduit choices and how different factors would affect their latency. Hoping that this will enrich your strategy and planning prior to revascularization. Okay, before we start the presentation, I would like to thank some people that helped me with the presentation. Dr. Abdullah Deeb, Dr. Layal Khalaf, Dr. Mohan Dawari, all some of my seniors that helped me a lot during the preparation of this presentation. Dr. Joseph Sapek and Rostrow, those are some of the adult cardiac surgeons, and they have different talks about advanced coronary surgery, and the concept that they present in these different talks were quite influential, and the studies and the data they showed, which I'll present in this presentation, inshallah. Okay, so let's begin. Now, when you talk about the success of Cabbage, you really talk about the patency of your graft. It is probably one of the most important factors in determining whether your procedure is successful or not. It's like saying when you're going for appendectomy, whether you remove the appendix or not. This is the same idea in Cabbage. To illustrate this point, this is a study, very old study in 1994 that looked into revascularization of the LAD. It took the IMA and the saphenous graft. But I don't want you to think of it as IMA versus saphenous. Think of it as this is a patent graft and this is not a patent graft or occluded graft. And this is showing the survival after 20 years. So the survival of the patent grafts is nearly around 80%. And in those patients who had the non-patent graft, 60% lived after 20 years. So this clearly shows that the effect of patency on the outcomes of your patients. Okay, so when we talk about conduits, we have a lot of conduits in cardiac surgery. Nowadays, we're using only few, but theoretically speaking, we have a lot. So what really determines your strategy and picking the different target and the different conduits? An easy answer would be saying, okay, let's just do all arterial, but this might not be the case in different individual. So what really determines your choices? These are some of the ideas or some of the concepts that you may think of, theoretical ones that you may think of prior to going to the OR. Obviously, intraoperatively, a lot of things can change, but prior to handling the case, you can think of a few things. And all of these are not related really to the patients. These are derived from the data that we know of Cabbage and revascularization. So we know time affects. And also one thing before we go talk about these different factors, try to think of them independently at the start and then later on integrate all of them. So we know time affects your grafts and their patency. Some grafts will be affected by the progress of time and some will not. Not all of them will react to the time similarly. Your surgical technique will determine the patency of your graft, and we'll be talking about the different anastomosis techniques. Your coronary targets, whether you're implanting whatever conduits that you have in different arteries, will determine the outcome. If you implant the saphenous and RCA or the LAD is completely different. And lastly, the different conduit choices, which I'll be talking a little bit about them, but they'll be discussed extensively in the last lecture of today. So the first determinant or the first notion that I want to discuss is time progress. This is showing, and this is the same graph that you'll be seeing in almost all studies that compare the saphenous versus the IMA. If you see on the x-axis, this is the passage of time or the years after Cabbage. And we can see after 16 years, not only 90% of the IMA grafts are patent, but also they are almost stable. It looks like the IMA is not affected by the passage of time. It's nearly timeless. However, if you look at the Safinus graph, it reacts differently to the passage of time. With more time and more years passing, the Safinus, more Safinus graphs will be included. And in different, this is showing around 50%, but in different studies, you'll see anywhere between somewhere in 40s up to the 60s. Okay, so the next thing that you'll be considering is what is your coronary target? Where are you going to plant the conduit that you have? Now, the set of graphs that I'll be showing, it talks about different implantation to different arteries. So we can, if you take the IMA in its own to illustrate this idea, if you implant the IMA to the LAD, the outcomes are going to be different from the RCA. It can be due to a lot of different factors, which we'll be discussing in upcoming slides. And if you implant the IMA to the diagonal circumflex or BDA, it's also the same. These factors can be the diameter of the vessel, the size mismatch, and the flow or competitive flow within these vessels. Now, we'll be talking about very important factors that comes in discussions when you pick the coronary targets. The competitive flow. Now, competitive flow affects different conduits differently, and also the competitive flow within each vessel is really different, which I will be explaining more in a few slides coming now. What I mean by that competitive flow within the RCA is maybe, we may think of it differently than the competitive flow within the LAD. Now, to illustrate this, this is the implantation of IMA within the LAD and within a non-LAD target. And if you look at the outcomes when you implant the IMA into the LAD, no matter what the proximal stenosis is, you're more likely to have a patent graft with the passage of time. However, when it's a non-LAD target, circumflex or RCA or BDA, the more proximal stenosis that you have, the fewer patent targets that you have after 10 years. This is the same thing, but now the different illustrations that I'm going to be showing, they all talk about, they all have the same structure. So on the y-axis, the patency at 10 years, x-axis is the proximal stenosis, and these are the graphs that have been used. On the left, it will be 1 year. On the right, it will be 10 years. And obviously, we'll show the targets that we implanted. Here you can see the implantation of ITA, or the anastomosis of ITA, to the LAD and the Safinus. This shows a very interesting thing, that it looks like the Safinus is not really affected by the proximal stenosis and the degree of it. However, the IMA is affected. But even if it's affected, that's why I said it doesn't matter over here. Even if it's affected, it's still more patent. When it's implanted to the LAD, it's more patent than the Safinus. And this clearly shows why you'd always implant the Lima to the LAD, regardless of the degree of stenosis, and you wouldn't choose the Safinus. Obviously, when this is indicated, and you wouldn't choose the Safinus over the Lima. Now, why is this? Why is this graph showing us this? Obviously, you all know from competitive flow that when you have competitive flow, or what is the idea of competitive flow? This is a situation when you have flow through the conduit and the native coronary and competition. And we all know from studies on arterial grafts that they have high vasoactivity or has high vasoactive capacity, and they can react to the reduction in graft flow, which is seen during scenarios of competitive flow. This low flow within the graft will lead to low endothelial stress. This is associated with few things that are very advantageous to grafts such as the Lima. When you have low endothelial stress, you'll have less production of nitric oxide, which is believed to be one of the advantageous things in Lima and why it remains patent throughout the time. Not only that, but also with less flow, you'll have several pro-atherogenic genes being activated within the vascular wall, and this will lead obviously to narrowing of the vessels. Now, this is for the lima. For the radial and the gastroepiploic arteries, they are even more affected by this phenomenon, by the competitive flow. And we'll show on some other slides. Now, for the saphenous, if you consider the arterial grafts being smart and reactive to different flows, the saphenous or the vein grafts are less smart. And the effects of competitive flow is quite minimal. They lack the ability, they have low variability within flow depending on the competitive flow, and they lack the ability to regulate blood flow within the coronary. For this reason, it's not as significant. Now, if you look into other arteries, when you implant the IMA to different arteries, the effect is just more dramatic depending on the degree of the stenosis. And if you look into the RCA, apparently the RCA is the worst of them all. So if you have more proximal stenosis in RCA, the worse the outcomes for the lima. So why is that the case? There are a lot of theories for that, but some of it will even we'll be talking about it during radial. But one of the things that you want to think about, all of these studies that are showing that I'm showing from these graphs, they were released before, or they were done on graphs with no FFR. And at that time, you would look into the degree of stenosis visually through angiogram. Now, what's the downside of that? When you look at the different stenosis at different segments of the artery, for example, if you take the LAD, usually we would implant it somewhere around L2 or L3. And from this study, the diameter of these segments can be around 1.7 to 2. And when you say that there is 50% stenosis here, we're talking about a flow that is going through a narrowing of only 1 centimeter. However, in the RCA, if there is stenosis within the RCA, let's consider the diameter of the RCA is somewhere around 4 or 3.9. And if you have 50%, that's around 2. So clearly the stenosis is different. The 50% within the LAD is different than the 50% within the RCA. All of this was done because it used to be visual. Now with the addition of FFR to our assessment of narrowing, this issue can be studied more, but this is one thing to consider. I hope that this idea is clear. If not, please feel free to ask. Okay, so this is another thing. If you're implanting, this looked at the saphenous vein patency when you implant it to the different coronary arteries and their diameters. If you have the diameter of the coronary artery more than 2, they are more likely to stay patent with the passage of time. And if you have smaller size of veins, they are more likely to be occluded. Now, talking about the different grafting techniques, you can either do in situ. So we have the lima, for example, come from the subclavian to the LAD. You can have it as a free graft, for example, in cases of rheuma, where you would cut it from the right subclavian and you would use it as a free graft. Other techniques that can be used is sequential grafting, where you have the lima supplying, for example, the diagonal and the LAD as illustrated here. Or you can have it as composite graft, where you'd have Y or T configuration. Now, few questions that arises when you use these different techniques. The first thing is, does using these different configurations will affect the patency of the vessel that I'm using? For example, in this instance is the lima. And the second thing, how about the flow within the end vessel? So here I'll show some studies that looked into these things. So to look into this, I want you to think of the different segments. So this is when you look into sequential, for example, there are two segments that are of interest. The segment prior to the first anastomosis and the segments after the first anastomosis. And in Y composite or in composite grafting Y configuration, there are three segments of interest. The one before the composite graft, the one after, and obviously the Y graft itself. This is showing all the segments, but let's look at it individually. So when you take sequential grafting, you can see this is as I said, this is the one prior to the sequential graft, and this is after. If you look at here, obviously there is a reduction within the segment after the sequential grafting, but if you look at the rate of occlusion, it's around 4%, which is significantly much better than venous grafts. So if you think about it, around 96% of the grafts after the sequential graft will be patent after the passage of time, nearly 15 years. While in 15 years, the saphenous will around 40 or 60% of them will be patent. Now, if you look at the composite graft, as I said, there are three segments of interest. The lima itself, we can see that it's almost not affected by using this technique. So both of them at 15 years will be patent, around up to 98 as shown here. However, there is some reduction within the lima-free graft that is used, so of around 8 to 10%. But still, again, the same thing is illustrated. This is still much, much better than using a vein graft. Vein graft, 40% of them would be patent by that time. Well, if you use a free graft Rima as a composite, maybe 10%, 90% will be patent. Now, this answers the first thing. Does using this configuration affect the patency of these grafts that you're using? Yes, to some extent, but still, that's much better than using vein graft. Now, is the flow within the LAD, which is the last anastomose vessel, is the flow really sufficient? Or are other arteries taking some of that flow? This is another study that looked into all of that while using either Rima or saphenous as a Y configuration. And you can, they studied that using FFR. And you can see that across all patients, all of them, their flows or their FFR ratio in the main stem and in the reta or the circumflex and the LAD, they're more than 86. And we know that reduction of FFR less than 80, that would lead to ischemia. So clearly we know that the flow within these arteries is sufficient. Now this is okay, so all of that is talking about the coronary targets. Now we'll talk about some of the individual conduits. This is no surprise to anyone. This is the same graph that I showed before, but now we'll talk about the actual details of it. So this is the EMA and this is the saphenous. And this is known since the beginning of dawn in the history of cardiac surgery. From the beginning of cardiac surgery, we started by using the Lima and Weinberg's procedure, where you just implant the Lima to a muscle, to the myocardium, and not really to a coronary. And at that time, it was patent and showing some survival benefit. So, and throughout the time when they studied this over and over again, we know that the Lima is much more, will stay much longer than the saphenous. And with the passage of time, obviously the saphenous grafts, nearly 60% of them would be included. Now, why is the Lima so special? Why, or the IMA, why is it so special? Why does it stay patent? There are a few things that may aid into that. First thing, the media is usually thinner. And this is advantageous when you compare it to other arteries. Why it would have higher patency rates, and why it's even affected less by compared to flow. With a thinner media, the IMA has less tendency to spasm. And also the perforation response is much less than, for example, let's say the radial artery. I already mentioned that there's intrinsic nitric oxide production and prostacyclin, which both of them are considered vasodilators. Now, this reduction does not only benefit the lima itself, but also the vessel that is anastomosed to it. So the LAD will get the benefit of this intrinsic vasodilation reduction. The lima also has a non-fenestrated internal elastic lamina. What does that help? It helps with inhibition of cellular migration, and which will eventually lead to prevention of the intimal hyperplasia. The lima shows favorable responses toward different pharmacological agents post-op. For example, the lima is usually vasodilates in response to milrinone, and it does not vasoconstrict in response to norepi, which are common medications that we use post-operatively. Obviously, its use, for example, if you're using the saphenous, you have two anastomoses. This will double the rate of your problems. You need to anastomose proximally and distally. So with lima, you only anastomose one side, which is the distal. This will cut down your complications to nearly the half. So that's one advantage. And obviously, it has good size match for the coronary arteries. This is to illustrate the media size, and it's clearly much thinner than the radial artery. Now, this is to illustrate some of the disadvantages of using, or some of the pitfalls of using a lima. This is from CAT. This is a CAT from a patient who already had CABG. You can see the lima going to the to this vessel, and the issue with this lima is that there is some stenosis within the subclavian. Now, if I would ask you a question, now this is a patient that is presented to you for a redo CABG. He had the previous lima to the LAD, and now it's a patient has subclavian stenosis. So every time she's using her hand, she's having anginal symptoms. What would be your revascularization strategy? Any answers? Any answers from our audience?
Carotid subclavian bypass.
Excellent. Yes, that's exactly what they did to this patient. Instead of doing full redo CABG, carotid to subclavian. Now I have a question. Is there any difference between the RIMA and the LIMA? Any answers?
Probably the same characteristics.
Sorry?
Probably the same characteristics in terms of histological. Although the advantage of the lima, I think the direction of the anastomosis, some say that the direction, how it, I don't know, stays or lay on the LAD has advantage in terms of anastomosis. What I know, it's histologically is the same. Probably I'm wrong, I don't know.
Excellent. Yes, that's exactly the case. There is no intrinsic difference between the RIMA or the LIMA. So in ideal world, they would both have the same patency rates. Now, their patency rates are different, but why? For two things. First, the lima is more likely to be anastomosed to the LAD, and we know that the anastomosis to the LAD carries more patency than being anastomosed to non-LAD targets. And the lima nearly always will be anastomosed if you're using it as a second graft. It will nearly always be anastomosed to non-LAD targets. So that's what the first thing. But now we have cases where the RIMA is actually anastomosed to the LAD. So we said that both of them are intrinsically the same. So why is there a difference between their patency rates? The only explanation that I could come up with is the explanation that Abdullah just provided. Obviously, now when you compare the use of bilateral or BIMA versus using single lima, in nearly majority of, if not all, of observational studies, they show clear survival benefits for using bilateral mammary arteries over the single mammary artery. But for some reason, there is always a discrepancy between these observational studies and randomized controlled trials, which is mainly the ART trial. The ART trial didn't really show any significant difference between these two vessels, and I think this will be discussed further in the last lecture. But it's very interesting that there are even some meta-analysis showing a lot of observational studies, and almost all of them would show some survival benefit. I know there are some critique within the ART trial. Hopefully it will be covered within the last lecture. Now, what are the downsides of using LIMA over a single LIMA, for example? The sternal wound complications, and this is especially the case for patients who have insulin-dependent diabetes or who are obese. However, there are some techniques around it. For example, using skeletonized technique when harvesting both the mammary arteries. However, this will clearly add a lot of time to the procedure. However, if you are a specialized coronary surgeon, this is definitely something worth looking at and improving your technique for. Another thing, the REMA length, especially when used in situ, sometimes it may be inadequate. Now, the second graft that people always talk about is the radial graft. Okay, 1 second, I'm sorry. Okay, I apologize for these technical difficulties. Anyway, if you look at this is a meta-analysis of different randomized controlled trials showing the outcomes, whether be it graft failure or death when comparing radial artery to the saphenous graft. And nearly at around 10 years, there is clear advantages to using the radial artery over the saphenous vein, which nowadays guidelines really endorse. Now, when you look at the radial artery, with the passage of time, depending on the, as we mentioned at the beginning of our presentation, if you remember, depending on where do you anastomose it, you'll have different outcomes. And this is probably due to what we mentioned about competitive flow and degree of stenosis. To illustrate this, if you anastomose the radial artery to a graft or a target that has critical proximal stenosis of between 90 to 100%, it has excellent patency. However, it decreases dramatically, especially if you have the target being, if you have the target with proximal stenosis of less than 70%. This is illustrated in this graph. The radial artery have nearly, in 2 years, have nearly the same outcomes of the LIMA when it's anastomosed to a coronary with critical stenosis in the left side. However, when you anastomose the radial artery to a moderately stenosed RCA, we clearly see that the patency rate is much less. And this is probably the case why the radial artery outcomes were much worse. Nowadays, we know that we need to anastomose radial arteries. And obviously, with all this data that we accumulated with the time, we know when to properly use the radial artery. So, for example, if you have an RCA that is not really fit the nowadays criteria for anastomosing radial, you're probably better served anastomosing a saphenous graft. That's why I asked in the beginning, what is the ideal conduit in anastomosing different patients? It's not always arterial grafts. Now, this is the last slide. It's showing, this is just one thing that has been going on over the last few years. A lot of people are trying to improve the outcomes and patency of vein grafts, since they are the most commonly used grafts and really the most convenient grafts being used. So one of the trials that was going on is the use of external support for saphenous vein graft, which is basically something that you would wrap your vein with to prevent overdistension because of when veins face the arterial pressure, which is believed to be one of the factors that affect the patency within veins. Anyhow, the results of this trial was just released this year, and I couldn't really get the full article. But from the abstract, they showed they didn't really achieve any statistical significance when using these devices. So these are the references that was not shown earlier within this presentation. Thank you, everyone.
Thank you, Walid. Thank you for this informative presentation. Just on the target. Anyone have any question for Dr. Walid? So it
Thank
seems
you. Thank you, Walid. Very nice presentation, thorough, and you nearly include all the studies. And actually, it's a nice summary to review the studies done on the grafts and conduit choices. Have you came across any study that talk about harvesting the IMA, the technique of harvesting? I'm not saying skeletonize or even for the pedicle, you know that it can be done in multiple ways. Some surgeons, they just take down part of it and they just burn the whole edges, and they do it in 10 minutes or less. Some they do clip branch by branch, the usual one. So any studies you came across that discuss this those different techniques and the patency?
That was question. That question was to me. For me, and I didn't see any.
Yeah. Okay. Okay. Thank you again, Walid.
Walid, did you have a consultant with you on this topic?
No, I didn't.
So it's always good to invite somebody whom you think that they have some experience, and some of you may have invited even people with international names. So, so to answer the question of Dr. Abdallah, is that there are different techniques of harvesting. Yes, I think you should start careful. Do not jump into the most necessary, jeopardizing the IMA graft. The reports, or you may have seen some surgeons that they do it fast. There's one surgeon who have the world record on this. His name is Charles Holman, and he did it he did it reportedly on 4 minutes. It doesn't mean that it's perfect. It doesn't mean that it's the way that you should go, but you should really start slow and protect the IMA, because the life of this patient will depend on that IMA. And as you develop your experience, then you proceed further. Faster does not necessarily mean better. At the end, you would know from your own results or from the studying of those patients with cardiac cath how many of them will have issues with the grafts. There was one study that came across, I came across I think it was 2015 in JACC, and basically they studied every patient who underwent cardiac cath, they had on the table angiograms. And they have found that there's an instance of about 7% of those patients who would require revision of the grafts, be it vein graft or Lima grafts. So be careful with those comments of being fast or things. I think aim for perfection. Thank you.
Thank you, Dr.
So just let's take a 10-minute for break, and we will start with Dr. Abir Al-Ghamdi for myocardial vascularization. Yeah, we can start, Dr. Abir.
Good afternoon, everyone. Today, my topic will be about coronary revascularization. Dr. Shabir, consultant cardiac surgeon in our hospital, is our guest today. Thank you. As in the previous academic activity last week, they talked about the coronary artery disease and the indication for CABG. We'll go directly, briefly to the preoperative assessment. In the preoperative assessment for a patient going for CABG, we should focus on symptoms and sign of ischemia, congestive heart failure, and valvular heart disease. We have to check if the patient have any comorbid conditions, such as CVA, peripheral vascular disease, malignancy, sternal radiation, COPD, diabetes, renal or hepatic insufficiency, DVT, or prior vein stripping. We have to review also the current medications, going through the cardiac cath and the echo, chest X-ray, ECG, and routine labs. The procedure and risk should be explained to the patient and his close family. Starting with the bypass conduit, we will start with the most important conduit in CABG. As Dr. Walid mentioned in his lecture, it's the first choice of graft to the LAD, as it demonstrates remarkable resistance to development of atherosclerosis. It's proven to provide superior early and late event-free survival after CABG. Comparing to the saphenous vein graft, it has lesser hyperplasia, as it has non-fenestrated internal elastic lamina with medial layer thin, with fewer smooth muscle cells. It has higher basal production of vasodilator nitric oxide and prostacyclin. It vasodilates in response to milrinone and nitroglycerin, and yet does not vasoconstrict in response to norepinephrine. Contraindication of using a single internal mammary artery: if the patient has previous radiotherapy to the left side, if there is atherosclerotic or stenosed left subclavian artery, but at that situation, we can use the graft as a free graft. If the patient going for emergency surgery for cardiogenic shock. Contraindication for bilateral mammary artery: if the patient has diabetes, particularly female, obese patient, current smoker, patient with COPD or other respiratory impairment, if there is immunocompromised patient, and patient who's on long-term high-dose systemic steroid. So talking about surgical anatomy of the internal mammary artery, it is the first portion of the subclavian artery opposite to the thyrocervical trunk. At the level of the clavicle and the first rib, the internal thoracic artery passes at first downward and medially behind the subclavian vein and lateral to the innominate vein. In this area, the phrenic nerve crosses the internal thoracic artery from its lateral to its medial side before contacting the pericardium. The phrenic nerve crosses anterior to the internal thoracic artery 66% of the time on the left and 74% of the time on the right. It is important to keep this relation in mind to avoid phrenic nerve injury during proximal internal thoracic artery harvesting. So the internal thoracic artery lies posterior to the cartilage of the upper 6 ribs and the intervening internal intercostal muscle. In the upper chest, there is a bare area of variable length where the internal thoracic artery is covered only by the endothoracic fascia and parietal pleura. Below this level, the transverse thoracic muscle covers the posterior surface of the internal thoracic artery. At the level of the 6th rib, the internal thoracic artery bifurcates into its terminal branches, the musculophrenic and superior epigastric arteries. The length of the internal thoracic artery in situ ranges from 15 to 26 centimeters. The left internal thoracic artery is slightly longer than the right. So we'll move to the how to harvest the lima. Good exposure is particularly important. The underside of the chest wall should be just above the surgeon's eye level. After the median sternotomy with the pericardium open or closed, place the mammary retractor in the incision and open it. Open the parietal pleura or keep it closed by dissecting it of the chest wall. If the lung obscures the view, you can either back it down with a large wet swab or ask the anesthetist to reduce the tidal volume. First, you should identify the lima. This is easiest proximally as it curves medially. With the dithermy on 60, make one trim line 3 to 5 millimeter medial to the medial mammary vein from the mandibulosternal junction to the xiphisternum. Some surgeon trim line the lateral side too. Turn the dithermy down to 30 and holding on the parietal tissue with the deep keys for countertraction. Use a combination of dithermy and blunt dissection with the flat of the dithermy blade to work the lima pedicle of the chest wall. Side branches are limited to the rib spaces, so it is easiest to get into the plane of dissection where the lima overlies the ribs. clipped the side branches, flush with the lima, and divided them at the schist wall with cautery. Now using dithermy, divided the parietal pleura on the lateral aspect of the lima to free the pedicle from the schist wall. Applying counter traction, divided the sided branches and fascia so that the proximal portion is free from the schist wall to the first strip. Give full dose heparin and check hemostasis. 2 to 3 minutes after the full dose of heparin is given, place a clamp over the distal stump, divide the mammary at the bifurcation, and check that there is a good pulsatile flow from the mammary, and then place a large Liga clip over the distal end. Flow often improves during the time between initial harvest and the LAD anastomosis. After that, wrap the mammary in a small swab soaked in babivarine and place it in the pleura for later use. Tie the distal stump with a 2-0 Vicryl. So patency of the internal thoracic artery, the superior late patency of internal thoracic graft to the left anterior descending coronary artery compared to a saphenous vein graft was initially demonstrated by Barner and colleague in 1985. There is superior patency translated into improved 10-year survival with the internal thoracic artery, with less incidence of myocardial infarction, hospitalization for cardiac event, and cardiac reoperation. In an angiographic study of 1,400 patients, symptomatic post-CABG patient, patency rate for the left internal thoracic artery at 10 and 15 years were 95 and 88% respectively, whereas saphenous vein patencies were 61 and 32 at the same time interval. Now moving to the second most common graft using, which is the greater saphenous vein. It's continued to be one of the most commonly used conduit in coronary bypass graft. It's easy to harvest, readily available, resistant to spasm, and thoroughly studied. Early aspirin administration reduced the mortality after CABG. So aspirin within 40 hours after CABG also reduced early post-operative complication, including mortality, MI, stroke, renal failure, and bowel infarction. Also, aggressive use of statin to achieve an LDL less than 100, it decreased by 1/3 of the number of graft affected with atherosclerosis at angiographic follow-up, and also decreased the need for repeat revascularization. When not to use saphenous vein graft, if there is overlying sepsis, if there is multiple large varicosities in the long saphenous vein itself, if patient has current DVT in that leg or previous DVT, if there is inadequate diameter lumen. So we have two techniques in harvesting the saphenous vein. It can be open or bridged. In the open, as we can see in the first picture, the section can be started in the upper thigh, above the knee, or at the ankle. Identification of the vein is easiest at the ankle, just above the medial malleolus. An incision is made overlying the vein and extended directly over its course. The vein is dissected and all venous tributaries are ligated and divided in situ. For the bridge technique, 2 or 3 step incision are performed over the course of the vein. Dissection of the vein is carried in a similar fashion as the open technique, except that the branches are divided in situ and ligated once the vein is explanted out. So once dissection is completed, the vein is ligated and divided proximally and distally. Stems of side branches on the vein are left long and then are ligated flush with the vein, avoiding narrowing of the conduit. The vein is then gently flushed and stored in a solution of room temperature. The skin incisions are closed and the leg is wrapped with an elastic bandage. We'll move to the third conduit, which is the radial artery. Histologically, the radial artery has a fenestrated internal elastic lamina and a thicker wall than the internal thoracic artery, with a higher density of myocyte in its media. It's more likely to have atherosclerotic changes at the time of harvesting than the internal thoracic artery. So indication for radial artery, if the patient is young, with age of less than 65, if there is a tight stenosis in a left side coronary distribution with good runoff. When not to use the radial artery, if there is poor Allen's test, if the target is unsuitable, if there is stenosis being bypassed is less than 70%, has poor runoff, or is a right-sided vessel. So we'll talk about harvesting radial artery. A medially curved incision is made on the forearm over the artery. The deep fascia of the forearm is incised directly over the artery. The brachioradialis muscle is retracted laterally. Dissection is begun at the distal end and the satellite vein are divided. The radial artery is harvested as a pedicle with minimal manipulation. The proximal end of the dissection is marked by the radial recurrent branch, which is left intact. After the pedicle is free and heparin has been given, the artery is divided proximally and distally and stored in a room temperature solution of lactate nitroglycerin and babavarine. Hemostasis of the operative field is obtained and the arm is closed in multiple layers. A closed section drain is also placed. Other conduits, arterial conduit, there is gastro, epibluic, ulnar artery, left gastric, artery, splenic, thoracodorsal artery, lateral femoral circumflex, and inferior epigastric artery. And there is also venous conduit, which is lesser saphenous vein and or upper extremity cephalic vein, which is rarely used. Moving to on-pump CABG. The procedure are done under general anesthesia with central venous access and radial arterial line. TE, it's useful for identifying unsuspected intracardiac lesion or aortic atherosclerosis and for evaluating ventricular function at the end of the procedure. If ventricular function is poor, a femoral arterial line will facilitate later placement of an intra-aortic balloon pump. After that, cannulation. After full systemic heparinization, cannulation of the distal ascending aorta is performed with an appropriately side curved or straight up tip aortic cannula. A venous cannula is used for access to the right atrium, usually through the right atrial appendage. Also, aortic root cardioplegia vent is placed. A retrograde cardioplegia cannula may be placed at the discretion of the surgeon. So if the patient with significant aortic regurg, he will get benefit from placement of the left ventricular vent, usually placed via the right superior pulmonary, to avoid distension of the left ventricle during infusion of the cardioplegia in the aortic root. Moving to the distal anastomosis, the arteriotomy site should be chosen proximal enough to offer the largest size coronary target, but distal enough to avoid area of obstruction. Arteriotomies at bifurcation should be avoided. So starting with sharp dissection of overlying tissue is required to identify the desired target site. The arteriotomy is then performed with a number 11 blade. The arteriotomy is extended with fine butt scissor proximally and distally. The arteriotomy should match the conduit diameter and should be at least 1.5 times the diameter of the distal coronary. Care must be taken to perform the arteriotomy in the midline of the coronary artery. An oblique incision results in distortion of the artery at the heel or toe of the anastomosis. And if an attempt is made to correct the direction of the arteriotomy, a flap of arterial wall is created. This leads to a less than perfect anastomosis. You have to take a special precaution not to damage the posterior wall of the coronary artery. This can happen if the angle of the blade is perpendicular to the vessel. So the angle should always be approximately 45 degrees with respect to the coronary artery. If the posterior wall has been incised through the adventia by the blade, it should be approximated with a fine suture of 8-0-prolene tied on the outside of the vessel. If difficulty is encountered in identifying an LAD artery, a fine probe may be passed retrograde via a small transverse arteriotomy into the LAD artery at the apex of the heart. The tip of the probe can be palpated in the proximal portion of the artery and cut down on appropriately. Don't force the probe. Don't use too big size. It might cause intimal injury. Okay, if the patient has intramyocardial course of the coronary artery, so we should follow the artery into the muscle, and the myocardial bridge over the artery must be divided with great caution. The intramyocardial segment of the artery is nearly always disease-free. The division of the myocardial bridge must be limited to the extent needed to perform a satisfactory anastomosis. Low current electrocoagulation is used to cauterize the edges of the muscular bridge. Positioning the heart to expose coronary artery. So if we want to see the anterior surface of the heart, a lap soaked in ice-cold saline solution is placed into the pericardium behind the empty and flaccid heart. In this position, the LAD diagonal and with some minor adjustment, ramus intermedius coronary artery can be viewed with ease. For the exposure of the RCA, it's usually a large vessel and is covered by epicardial fat in the right AV groove. Its distal branches, the posterior lateral and PDA, tend to be more superficial as they course toward the apex of the heart. The acute margin of the right ventricle is gently elevated and held in position by the assistant surgeon hand. The distal RCA and the proximal segment of its branches are brought into view. Distal RCA is usually palpable. The epicardium over the AV groove is incised. The distal RCA is identified and dissected for a short distance. To provide exposure for the PDA or posterior lateral artery, the apex of the heart is elevated toward the patient's right shoulder. So now we'll talk about distal anastomosis suture technique. The conduit is beveled at 30 degrees and notched at the heel. We use a continuous parachuting technique with 7/0 or 8/0 Prolene suture. The conduit is brought into the field with a mosquito clamp on the adventitia at the toe of the conduit. An end-to-side anastomosis is accomplished with 12 suture, starting at 3 o'clock on the right side of the vessel. The suture is passed outside in on the conduit and then inside out at the corresponding location of the target vessel. 2 more stitches are taken before the heel, 1 directly in the heel, and then 2 more on the left side of the anastomosis before parachuting the conduit down to the target vessel. The anastomosis is then completed by placing another 6 stitches evenly spaced in the same manner for the toe. Now we'll talk about the sequential anastomosis. When we do sequential grafting, it's permit efficient use of the conduit and has the potential for increased flow in the conduit. When planning sequential anastomosis, the most distal anastomosis should be to the largest target vessel with the greatest outflow potential. If the reverse situation is created, the most distal anastomosis is at increased risk for failure, giving the likelihood of preferential flow to the larger, more proximal anastomosis. A clear disadvantage of sequential grafting is the reliance of 2 or more distal targets on a single conduit and proximal anastomosis, placing a potentially large region of the myocardium at jeopardy if occluded. So for the order of sequential anastomosis, the order is performed. The order in which sequential anastomosis are performed is important to facilitate optimal intergraft spacing and avoid kinking. The distal anastomosis is completed first, and the more proximal sequential anastomosis is performed secondly, except for an LAD diagonal graft, in which the diagonal is performed first, followed by the LAD. For the peripendicular sequential side-to-side anastomosis, arteriotomy are made in the direction of the long axis of the coronary and the conduit. Care must be taken not to make the arteriotomies too long because there is risk of creating a gull wing deformity. The 2 incisions are aligned perpendicular to one another. Suture is passed starting inside out at the apex of the target coronary and then outside in at the mid portion of the conduit. An 8 stitches anastomosis is completed, creating a diamond-shaped anastomosis. Moving to the longitudinal sequential and side-to-side anastomosis, arteriotomy for longitudinal anastomosis may be made as long as necessary without risk of distorting the conduit. The anastomosis is begun at the heel and the far wall is completed open. It is then parachuted down and the front wall completed. Now we'll move to the proximal anastomosis. Proximal anastomosis of the saphenous vein or the radial artery to the aorta are performed after the distal anastomosis under the same cross clamp. Our preferred technique is to complete each respective bypass graft in a distal anastomosis, proximal anastomosis fashion. Completion of each prospective bypass graft allow antegrade cardioplegia down the completed graft, aiding in myocardial protection. The graft is measured to length with the aorta and right heart failure, pulmonary artery full of blood. So the proximal anastomosis is performed using a single clamp technique. In this images, we can see it. The fatty tissue overlying the bland aortotomy site is removed, and arteriotomy is created with a number 11 blade. A 4 to 5 millimeter aortic punch is used to create a circular aortotomy. The size of the punch will vary depending on the size of the conduit graft. So the proximal aspect of the conduit is beveled and then notched at the heel. A running 5/0 or 6/0 Prolene suture is used for a venous graft and the 6/0 or 7/0 Prolene suture for an arterial conduit. The long axis of the graft is aligned at an appropriate angle to the ascending aorta. The anastomosis can be completed with 8 stitches in most cases. Symmetry in the spacing between stitches is important to ensure the hemostasis. We'll talk about the composite graft. It's an alternative to the proximal anastomosis to the aorta. A free graft can be anastomosed proximally to the pedicled internal thoracic artery. Composite grafting is a useful tool for the hostile calcified ascending aorta or when there is a limited length of the conduit available. So a coronary artery bypass graft is used as a donor site for, like the Lima, for the proximal anastomosis of another conduit. So an incision is created in the donor conduit. The proximal end of the recipient conduit is then anastomosed to the donor site in an end-to-side fashion, as previously described for a distal anastomosis. The recipient conduit is then gently parachuted down onto the donor conduit. I will conclude my presentation with the causes of death after CABG. The most common cause of death after CABG is heart failure, 65%, following by neurological causes, hemorrhage, respiratory failure, and dysarrhythmia. The greatest variability in mortality rate observed across surgeons is attributable to differences in rate of heart failure. Thank you.
Thank you, Dr. Abir, for your presentation. So the second presentation will be with Dr. Faris. Faris, are you available?
Yes.
Yeah, we will just take 5 minutes for rest and we will start the presentation, inshallah.
Hello, assalamu alaikum.
Salam
Alaikum salam.
Okay. I'm Dr. Shabir. I was listening to this Dr. Abir presentation, very good presentation. It was very, to the point, very practical point of view. It's a nice presentation. So this is a routine affair of CABG, so nothing special. But if anybody has any questions, you can ask, something in mind you observed, in your OR and your practice and you couldn't find the answer. If anybody has any questions, then you can ask.
Thank you, Dr. Shabir. I have a question, if you don't mind. In a patient with end-stage renal disease and he had the left AV fistula, would you use the Lima for the graft?
No. There is no big studies like this, but usually we try to avoid when there is AV fistula in the left arm. Any specific reason? To be honest, I don't know because I have not done anything like this. So, you come any study across? You are aware of? The general practice is like that. We don't do it. But you have any study in your mind you recently read or something?
No, actually. But we had some patient that we did not use the Lima. We used the vein for the LAD.
Yes. Okay.
Thank you.
No, same thing. Yeah, okay. Any other? CABG is the commonest operation. There are so many things, so many on pump, off pump, the conduit issues, so many things, to discuss. So sequential, no sequential, bilateral, unilateral. I think you guys know everything about CABG. That is great.
I'll just have a comment on the mammary and AV fistula. To my knowledge, it's not an absolute contraindication. It's a relative contraindication to use Lima in patient with AV fistula, as you increase the risk of the coronary steal. Some paper will argue that it's the risk of coronary steal is not that high, and it has been done, and I've seen it. And so far, the patient, up to my knowledge, the patient didn't have any ischemia related. The other will argue is looking at long-term survival. Patient with end-stage renal disease with AV fistula, they have a very poor outcomes. So if you're harvesting the Lima to increase survival, it might be not the you may not use it or achieve that in patient with end-stage renal disease. But for your exam, it's not an absolute contraindication.
Yes, you are right. You cannot define here contraindication or no contraindication. The basically, when you make an AV fistula, there is lots of arterialization of the veins. So your runoff in the vein, the arm is too much. It takes lots of cardiac output. You will see the AV fistula, you may have even edema or, the vascularity is too much. So it may occur a steal phenomena because of the too much runoff. That is why you should avoid. It is difficult to say contraindicated or not indicated. In your practice, you should try to avoid. If you have done it or you have seen doing and nothing happens, it is okay. But you should try to avoid it.
Dr. Shabir?
Yes.
It's good to hear your voice from time to time. This is Farid Khogir.
Assalamu alaikum. How are you, sir?
Alaikum assalam wa rahmatullah. So the comment was coming from Dr. Al-Umair, who just joined us in King Faisal as a locum as a consultant locum.
Oh,
She
mashallah,
just,
okay.
yeah, she
Oh,
just,
I thought this, okay.
yeah. And she had great experience from Toronto. I guess she's passing that information because of what she's seen, and maybe also some few articles on the topic. So just like you said, if you have any high suspicion of complication, it's better to avoid it. Otherwise, it's not an absolute contraindication. Thank you.
Yeah, absolutely. That is what you should try to avoid, but there is no contraindication. I agree.
Yeah, totally agree, Dr. Shabir. Thank you.
Another option would be probably using it as a free graft. It also has all the characteristics, and just taking off the lima and using it as a free graft to a lady, benefiting from its characteristics.
I couldn't hear the question. What was the voice was not clear.
Yes,
you
sorry,
repeat
Ricochet. No, I was saying that it can be used as a free graft instead of
Okay,
in situ, yeah, as a free graft, the IMA, the Lima,
yes.
to the LAD, yeah. In that
Yes,
instance,
basically, yes, the renal failure group is a totally different group. You know, their overall prognosis, as Dr. Farid was the other consultant, sorry, I don't know how, they don't have a long-term good prognosis anyways. Operating in end-stage renal disease, you have to be careful because the things are all calcified and the long-term prognosis is not good. So, but in renal failure patients, I think PCI, stable coronaries, has hardly any role, maybe very few or selected cases. But the CABG has a better prognosis than the PCI. So in renal failure, we'll still try to operate them, and particularly try to use the the arterial graft. I agree that if you are concerned, just take a free graft is better than the vein graft. Thank you.
So our next topic will be venous versus arterial conduit in CABG. We will start with pro-arterial with Dr. Faris. Dr. Faris, you can start, please.
Okay. Okay, Assalamu alaikum. Good afternoon. My name is Faris Bainain. I'm a cardiac I'm hospital in Jeddah. And today I'm going to talk about arterial conduit.
Dr. Faris, your voice is not clear.
Okay, I will. No issue. Is it clear now?
Yeah.
Okay. So today I'm going to talk about arterial conduit. Arterial is venous single intramammary artery versus bilateral. secondary conduit, multiple versus single arterial graft. Okay, in this article, influence of the internal mammary artery graft on 10-year survival and other cardiac events, they compared patients who received an internal mammary artery graft to the anterior descending coronary artery alone or combined with one or more saphenous vein graft, number of 2,306, with patients who had only saphenous vein bypass graft, number of 3,625. Oh my God. That's moving. The method from among the first 1,000 patients undergoing isolated coronary bypass grafting each year, the Cleveland Clinic Foundation from January 1, 1971 to January 1, 1979, they chose for this study who had narrowing of 50% or more of the anterior descending artery with or without coronary arterial lesion, and who received a vein graft or an internal mammary artery graft to the anterior descending artery with or without other vein graft. Because of this large number of cardiac operation and complexity of large scale follow-up, they routinely studied the first 1,000 consecutive patients who underwent isolated coronary artery bypass annually. This number provides large and uniform count from each year for analysis. They excluded a patient with stenosis of 70% or more in the left main coronary artery, those who underwent emergency coronary artery bypass grafting, those who had previous cardiac operation, and those who received bilateral internal mammary artery graft, sequential internal mammary artery graft to vessel other than the anterior descending artery or pre-internal mammary artery graft. Patients who died in the hospital after operation were also excluded. This includes 12 or 0.52% of the 2,318 patients who received internal mammary artery graft and 64 or 1.72% of the 3,689 patients who received vein graft. Thus, the patient still included 2,306 who had an internal mammary artery graft to the anterior descending artery with or without vein graft to the other coronary arteries, and 3,625 who had only vein graft. In survival, among patients with single vessel coronary artery bypass grafting, those with internal mammary graft had a 94.4% survival rate as compared with 88% for those with saphenous vein graft. Among patients with two vessel coronary artery bypass grafting, those with internal mammary artery graft had a 90% survival rate as compared with only 79.5% for those with saphenous vein graft. Among patients with three vessel coronary artery bypass grafting, those with internal mammary graft had a 82.6% survival rate as compared with only 71% for those with saphenous vein graft. In cardiac events, patients with vein graft had 1.41 times the risk of left myocardial infarction, 1.25 times the risk of the cardiac hospitalization, and 2 times the risk of cardiac reoperation. In graft patency, internal mammary artery graft was a 96%, whereas the vein graft was only 81%, and we can see in the vein line declining over the year. In conclusion, 10 years after sequential angiogram disclosed that the left patency for the mammary graft was significantly higher compared to the vein graft. This information, coupled with their finding of the vein graft atherosclerosis as increasingly common reason for reoperation. So there was a difference in delayed development of atherosclerosis between patients with internal mammary artery graft and vein graft. This important difference in patency appears to be the major reason for the difference in late clinical results between the two groups. Okay, in this article, a meta-analysis comparing bilateral internal mammary artery with left internal mammary artery for coronary artery bypass grafting between January 1972 to December 2012. A total of 27 observational studies were included. No randomized control trial, 24 were retrospective cohort studies, and 2 were prospective cohort studies. The 27 studies included a total of 79,063 patients, of which 19,477 were bilateral internal mammary artery and 59,786 were left internal mammary artery patients. Duplicated study review article, case reports, conference presentation, and expert opinions were excluded. This meta-analysis demonstrated statistically insignificant benefit in survival for patients receiving bilateral internal mammary artery versus left internal mammary artery for bypass grafting over the other candidates. So, with the increasing evidence that shows long-term survival advantage for patients receiving bilateral internal mammary arteries, why are so few patients undergoing this operation? Currently, the majority of patients still receive only left internal mammary artery, despite the fact that the available evidence shows increased survival in patients receiving bilateral internal mammary artery. The bilateral internal mammary artery operation is by all accounts for a longer operation that requires more patience and more surgical skill. This meta-analysis was limited by the nature of the studies included. Observational studies only, no randomized controlled trials has been reported with full long-term follow-up in this meta-analysis. In bilateral versus single internal thoracic artery graft at 10 years, a multi-center randomized and blinded trial at 28 hospitals in 7 countries: Australia, Austria, Brazil, India, Italy, Poland, and the United Kingdom. A total of 3,102 of those 1,548 patients were randomly assigned to undergo bilateral internal thoracic artery grafting, the bilateral artery group, and 1,554 to undergo single internal mammary internal thoracic artery grafting, the single graft group. The primary outcome was death from any cause at 10 years of follow-up. Secondary outcomes were development of myocardial infarction or stroke or repeat revascularization and safety outcomes. Okay.
Dr. Faris, that's it? You finished already?
No, it's not. But it's not moving.
Okay.
I don't know. I'm sorry, but my device is not responding.
No, it's okay. Just take your time to fix the session.
Yeah. Yeah. So I was saying the primary outcome was death from any cause at 10 years of follow-up. Secondary outcomes were development of myocardial infarction, stroke, rate of repeat revascularization, and safety outcomes. The inclusion and exclusion criteria were eligible patients were those with multi-distal coronary artery disease who were scheduled to undergo coronary artery bypass grafting. Patients for whom only a single graft or component surgery was planned, as well as those with a history of coronary artery bypass grafting were excluded. Patients were randomly assigned in a 1-to-1 ratio to undergo bilateral or single internal thoracic artery grafting. This table shows the demographic characteristics of the patient baseline with the age of mainly 63. For both group, male was the majority. Also, the white race also was the majority, and no history of diabetes also was a large number. In 3,102 patients in the randomization, 1,554 were assigned to single graft group. Of those, 1,546 underwent surgery, 1,494 received single graft, 38 of those received bilateral graft, 14 underwent other procedure, 8 did not undergo surgery, 1 died before the surgery, 2 had surgery canceled, 1 underwent PCI, 4 withdrew from trial. Of those, 328 died, 27 were lost to follow-up at 10 years, 5 withdrew. Lastly, 1,189 were known to be alive at 10 years. 1,554 were included in primary analysis. The other group were 1,548 assigned to the bilateral graft group. Of those, 1,531 underwent surgery, 1,294 received bilateral graft, 215 received single graft, 22 underwent the other procedures, 16 did not undergo surgery, 1 died before the surgery, 3 had surgery canceled, 3 withdrew consent for surgery, 1 underwent PCI, 8 withdrew from trial. 1 received unknown treatment. Of those, 314 died, 24 were lost to follow-up at 10 years, 3 withdrew, and 1,198 were known to be alive at 10 years, and 1,548 were included in primary analysis. This table shows us the clinical outcomes and adverse event at 10 years. The two groups, a bilateral group and single group, clinical outcome, primary outcome, death from any cause. We can see in the single graft group have the higher number, 329 versus 315 in bilateral graft group. In composite of death, myocardial infarction or stroke, also in single graft group was having a higher percentage of 425 versus 385 in myocardial infarction. Also in single graft group was higher of 78. Stroke also in single graft was higher of 76. In adverse event, we can see in bilateral group was higher. And repeat revascularization was 159 versus 156 in single graft group. And major bleeding was 52 in bilateral group versus 48 in single group. Sternal wound complication was higher also in the bilateral graft group of 54. In sternal wound reconstruction was higher also in bilateral graft group of the number of 31 versus 10 in single graft group. So the conclusion, ART was randomized trial that compared bilateral with single internal thoracic artery grafting for coronary artery grafting at 10 years. There were no significant difference between group in all-cause mortality, in the rate of the outcome of death, myocardial infarction or stroke, or in the rate of repeat revascularization. There are several possible reasons for the lack of the evidence of benefit of bilateral internal thoracic artery graft as compared with single internal thoracic artery graft in ART. First, 22% of those who had randomly assigned to the single graft group also received a second arterial graft in the form of the radial artery graft. Secondly, 14% of the patients who had been assigned to the bilateral graft group actually received a single internal thoracic artery graft, which may have influenced the relative effectiveness of the bilateral internal thoracic artery grafting. Okay, association between radial artery graft to single and bilateral internal thoracic artery graft outcomes. Patients enrolled in ART number of 3,102 were classified on the basis of conduits actually received whether single or bilateral internal thoracic artery. The present analysis compared the strategy using a radial artery with additional stiffness vein graft, the radial artery group versus graft, stiffness vein graft only, stiffness vein graft group. To supplement either single artery, single internal thoracic artery or the bilateral thoracic artery graft. The following patients were excluded from the present analysis. Neither stiffness vein graft nor radial artery was used, number of 328 patients. Patients receiving stiffness vein graft, but neither a single internal thoracic artery nor bilateral internal thoracic artery graft, number of 30, and patients receiving radial artery graft, but neither a single internal thoracic artery nor bilateral internal thoracic artery used, number of 7. So the final population included 2,737 who received radial artery graft, radial artery group of number of 632, or stiffness vein graft, stiffness vein group number of 2,105. In this table, we can see the 5-year outcomes rate with 95% confidence interval. Radial artery group, stiffness vein graft group unmatched, and stiffness vein graft group matched. In myocardial infarction, we can see the stiffness vein graft group unmatched having the higher number of 28, and repeat revascularization of stiffness vein graft group unmatched having the higher of 152. Also in cardiovascular death, 73, and stiffness vein graft group unmatched. Overall death also higher in stiffness vein graft group unmatched of 189, and cardiovascular death, myocardial infarction or revascularization also number of 261 with the stiffness vein graft group unmatched. The conclusion, the main findings of the present analysis is that radial artery graft with or without additional vein graft used to supplement either single internal thoracic artery and bilateral internal thoracic artery graft instead of stiffness vein graft was associated with significantly lower rate or major adverse cardiac events, with significantly a lower rate of re-intervention and marginally lower risk for cardiovascular death and subsequent MI. From these results, it seems reasonable to consider the use of an radial artery graft a valid option for multiple arterial grafts. The RAPO trial or radial artery latency and clinical outcomes. Coretia right internal thoracic artery. Number of 394 patients younger than 70 years of age or 60 years of age if they had diabetes, or randomized to receive radial artery or free right internal thoracic artery on the second most important target coronary vessel. RAPO stiffness vein, a number of 225 patients 70 years or more of age or 60 years of age if they had diabetes were randomized to receive radial artery or a stiffness vein on the second most important target coronary vessel. The radial artery was unusable in the presence of abnormal Allen test, 10 seconds or more, or abnormal digital brachial index of 0.8 or less. The free right internal thoracic artery was unusable after previous thoracic trauma or chest radiotherapy or in the presence of severe airway disease. The stiffness vein was unusable in the presence of varicose vein or a previous leg trauma. Okay, including criteria, a patient undergoing elective isolated coronary artery bypass graft requiring more than one bypass conduit were eligible for the trial. An ejection fraction of 35% or more, and at least one non-LED vessel with proximal stenosis of at least 50% and diameter of at least 1.5 millimeters. Exclusion criteria were patients with body mass index of more than 35 kg per meter square, renal impairment with serum creatinine level more than 300 micromole per liter, lung disease with a forced expiratory volume of 1 second, less than one, and major illness for like emergency and survival less than 10 exclude. The outcome, radial artery versus right internal thoracic artery, failure of radial artery versus right internal thoracic artery occurred in 15 versus 23 patients. 10-year patency estimates were 89 and 80% for the radial artery and right internal thoracic artery, respectively. There were 11 versus 13 myocardial infarction and 22 versus 26 a repeat revascularization in the radial artery versus right internal thoracic artery group, respectively. There were 50 deaths during follow-up with 18 and 32 deaths in the radial artery and right internal thoracic artery group, respectively. And 10-year estimate of survival at 10 years were 90.9% and 83.7% in the radial artery and right internal thoracic artery groups. In saphenous vein, radial artery versus saphenous vein, graft failure occurred in 6 radial artery and 12 in saphenous vein. The 10-year estimate patency were 85% for the radial artery and 71% for the saphenous vein. There were 31 deaths in radial artery group and 39 deaths in saphenous vein group. A 10-year survival was 72.6% versus 65.2% in the radial artery versus saphenous vein group, respectively. There were 8 myocardial infarction in the radial artery group and 10 in the saphenous vein group, and 7 repeat revascularization in radial artery group versus 9 in the saphenous vein group. So the conclusion found that the radial artery has significantly a better 10-year patency rate than the right internal thoracic artery and higher, although not significant, 10-year patency rate than the saphenous vein. These findings support the use of the radial artery as the free conduit of choice to the complement of the left internal thoracic artery in coronary surgery. Okay, randomized comparison of the clinical outcome of single versus multiple arterial graft, the Roma trial.
Faris, I'm sorry, may I say something, please? Faris, we don't want all these details. This is Dr. Al-Amoudi. We need you to be a little bit more precise and short, because this is a debate, should be focused, what is significant, what's not significant. So we need people to be with you and focusing with you. We don't want all the numbers. Say what's important, just be a little bit short if you don't mind.
Yeah, sure. From the end of the last thing. Okay. So this the last thing. It was a prospective and blinded randomized event driven multi-center, 4,300 patients, 21 fashion between the two groups. Primary outcome used 2 or more arterial grafts compared to single arterial graft rate with reduction of the composite outcome, death of any cause, any stroke, both discharge, myocardial infarction, or repeat revascularization. Secondary outcome, the use of 2 or more arterial grafts compared with survival. Okay, inclusion and exclusion criteria. Including criteria, primary isolated coronary artery bypass grafting, a patient with disease of the left main coronary artery and or the left anterior descending and the third coronary system with or without disease of the right coronary artery. Exclusion were age more than 70 years, single graft emergency operation involving myocardial infarction within 48 hours of surgery. Left ventricular ejection fraction less than 35%, any concomitant cardiac or non-cardiac procedure, previous cardiac surgery, severe organ dysfunction, inability to use saphenous vein, bland hyperrevascularization. This is an ongoing randomized comparison of the clinical outcome of single versus multiple arterial graft Roma trial aimed at examining the effect of multiple arterial during bypass grafting, the effect of the second arterial grafting on both operative outcomes, the effect of using 3 or more arterial grafting, and the relative role of the right internal thoracic artery and the radial artery, second or third arterial graft are all open interrogations that have not been tested in adequate randomized trial. The Rome trial was conceived to provide answers to those open questions. And thank you.
Thank you, Faris, for your presentation. So now we'll go for another presentation. Is there any question for Dr. Faris? So it seems there is no question. So we'll start with the proof venous with Dr. Abdelkarim Abu Khader. Abdelkarim, you are ready?
Can I have a question just before we start the venous?
Yeah, sure.
My question is to Faris. Faris, you gave a lot of information and data, but in summary, how would you advocate for use of total arterialization? In summary, like 2 sentences, and support your answer with the trials.
Okay, in summary, why the arterial conduit is better than venous? As I mentioned in the presentation, we can talk about the rate of survival or the adverse event is all less presented with the arterial conduit than the venous. The first article was the pulmonary artery graft at 10-year survival. The single or the single vessel, 2 vessel or 3 vessel, all were less or higher percentage in survival in arterial conduit than in venous conduit. Also in the patency rate, with the 10-year, 5-year, and 10-year arterial conduit having a better patency rate than the venous conduit. So that's why I think the arterial conduit is better than the venous conduit.
Thank you.
Thank you.
Is there any more question? So just let's welcome by Dr. Walid Abu Khader, the head of department of Army Hospital in Jeddah, our new guest consultant, Dr. Hussein Al-Amoudi from Western Ontario University, adult cardiac surgeon, Medina Cardiac Center, and RTB. We can start, Dr. Karim.
Yeah. So my name is Abdelkarim Abu Khader. I'm in R1 in Medina Cardiac Center. Thank you for the opportunity to present this topic. And I'd like to thank Dr. Hussein and Dr. Walid Abu Khader for joining us, and also Dr. Shabir. So I'm going to defend essentially this, the venous conduit. It doesn't have a lot of people defending it at the moment. I think that possibly in the future, the Lima and the saphenous will still be the most used conduits. This is my opinion. So I'm going to start with venous conduits, then we're going to talk about the great saphenous vein, and then what is the case for the great saphenous vein. Next, I'm going to target the BEMA versus SEMA trial, and then some radial versus great saphenous vein trials, and then finally just touch on the complications of harvesting radial and saphenous and the no-touch technique. So this is just a quick picture. We can easily see the difference. Larger lumen over here for the veins, smaller tunica media. The differences between this were explained very well in the first lecture, so I'm not going to go over that in detail. But essentially, the nitric oxide, which was mentioned by Dr. Walid, is something that is really important, especially in early graft failure and long term. So these are the different vein grafts we have. Great saphenous is the most widely used, and then we have the small saphenous vein. A good alternative, but difficult positioning because you have to go from the posterior side of the calf of the leg. And then finally, the upper extremity veins have been used in the past, not so much anymore. So this is the guy that really did the first saphenous vein anastomosis in 1967. Favaloro, his name. And in 1986, the Lima showed to be better than the LAD, which is fine. I mean, Dr. Faris and Dr. Walid talked about the Lima, and we don't have any problems with the Lima being the best. It is the best. It's better than the radio as well, and the Lima for LADs. So they can have that. The question here is going to be the second conduit. That's going to be our topic over here. These are just different harvesting techniques. You know, the conventional, the sequential, and then we have the endoscopic. And this is actually quite important because I'm going to be touching on the no touch technique, which is very interesting, overlooked, I think, and is essentially it essentially shows that the saphenous vein just has more to give than what we're using it as right now. So we might have reached our peak with the Lima, maybe even the radial. Maybe the radial could be improved. You know, we can't know yet. But the saphenous definitely has room for improvement. And if we can capitalize on that, then we can keep it. And it is a very simple structure. It's not that hard to get, relatively speaking. It's convenient. We're not going to have any infections in the chest, and of course the arm. The arm is not really a nice place to have a scar. And it is more convenient, easier to use, easier to handle. We say it's easier to handle. However, we just become a little bit more rough with it, which is not fair. So the case for the saphenous vein grafts is essentially the associated limitations of the arterial grafts, and then the bilateral Lima, which did not show to be better than the single internal memory in the largest 10-year RCT. And then we have the fact that there hasn't really been a single RCT that has showed improved, essentially like more mortality and clinical outcomes for the radial grafts over the saphenous vein graft. So this is the saphenous versus the radial, and this is really important. The no-touch technique compared to the conventional vein harvesting has shown significantly better results angiographically and clinically in preliminary RCTs and other large prospective studies. And I'll be talking about this too. So the no-touch technique has proved to be significantly better than the conventional vein harvesting in both angiographical and clinical scenarios. And finally, the simplicity and the convenience of the great saphenous vein. I mean, we cannot overlook that at all. Even though they have ranked it in the guidelines, in the American guidelines, the recent ones, they're recommending arterial, but even in America, they're not doing radials as much as they're doing saphenous by far. So we can't overlook this convenience and simplicity of it. And if we can improve it, then we should, instead of going and looking for something that is more difficult and for maybe not really a significant benefit. So let's start with the limitations of the arterial grafts. I put a few in over here. You know, increased risk of mediastinitis, terrible thing to have, chest infections. Might not be worth the risk if there's not a significant benefit to it. This is, of course, especially when using the bilateral internal thoracic arteries. And then we have poor results, obviously, when targeting vessels that are less than 70% stenosed. And that goes into the first lecture we discussed. And then we have, obviously, the spasms that are in the free grafts. And just, it's more technically demanding. The radial, if we're talking about the radial, then it's too close to the chest. You can't have two people standing next to you can't have like a main surgeon and assistant standing there. You're gonna have to wait for the guy that's doing the radio, and if you do bilaterally, that takes a lot of time. These are all kind of the limitations of the RTL, and the benefits of the saphenous, we know the convenience and more easy to dissect. A little bit of a strange anatomy, but it's all right. So the first thing I'm going to do is I'm essentially going to eliminate the BIMA, which is the obvious first step for me in this debate. Honestly, I started not really trying to do a debate, but then when I realized that the vein really needs somebody to speak for it, that's why I'm trying to really see if we can reach somewhere with this. So BIMA versus SEMA shows no difference in outcomes. Obviously, the ART trial, they released a 10-year follow-up in 2019. Dr. Faris thankfully extensively covered this. So it was bilateral versus unilateral. This was an RCT, a large RCT with a 10-year follow-up. Additional arteries or vein grafts were used as indicated. Primary outcome was death from any cause, 10 years. And then, okay, so we already discussed it. I don't want to go over it again. Just to know that the radial was used in 20% of these cases as secondary conduit. I didn't put in the criticism because I don't really think it's essentially a criticism of the trial. I mean, it was comparing, in terms of the goal of the trial, it was assessed. And even if you're speaking in terms of the saphenous, 20% is not really that much. And I suppose the BIMA should, or people assumed it would have been better, regardless of using radio. So as we can see, it's a large trial, 3,000 patients, and then they ended up with around the same number. Primary outcomes, secondary outcomes. We have sternal wound. So these are the results. So we can see there isn't really a significant difference at all, really, in any of their outcomes, except the safety outcomes, which was the sternal wound complications. And they actually had quite higher sternal wound complications. These are the graphs. We can see the one on the left is death from any cause. It's the same, essentially, not really significantly different. Same thing on the right. The SEMA versus the BIMA. The SEMA is blue, the BIMA is red. Over here we have a forest plot chart over here. This was showing the subgroup analysis. They didn't really find anything significant over there either. So that wrapped that one up. And the bottom line was that the BIMA and the SEMA had similar results 10-year, and there was a 1.6 absolute increase in sternal wound complications using the BIMA. And you can see here that, I mean, we can talk about patencies and we can talk about all that stuff. It's not really as important as our main objectives, which is increase quality of life and increase lifespan, essentially. Those are our two goals. Those are always have been our two goals. The guidelines have always said that those are the most important things: clinical outcome and mortality. So quality of life and mortality. And over here we see that only the quality of life is affected for the worse. The criticism is that 84% of patients that were supposed to take the BIMA actually took the single. Sorry, there's a mistake there. Different aspects of surgical techniques were not controlled. And obviously the open label trial design allows for potential bias in the assessment of the outcomes. The criticism here, I don't see really a strong criticism against the BIMA, maybe except the radio, but that shouldn't really be a problem. So that's the BIMA. The BIMA is out essentially until the Roma trial comes back, and then maybe we can we can see. And the next point is no single RCT favoring radial over saphenous. And I brought the same trial as Dr. Faris did. Maybe for him, this trial is a benefit for the arterial, but for me, I see it as a benefit for the saphenous, or not really something that's that bad for the saphenous, because in the end, there weren't any clinical outcomes. And this is what I'm trying to say. This is a 10-year RCT. I'm not trying to get any prospective studies here, or even some meta-analysis have bias, more biases than RCT. These are all RCTs, all well made. So let's go through with it. So again, he really talked a lot about the design and stuff. So I'm going to go through it very fast. So 600 patients, 400 in the Rapco arm, and then 200 in the SVG. So they started with the Rapco arm, and then they later on decided that saphenous, essentially. That's what happened. And then, so all conduits were used just as aortocoronary grafts, so no Y graft configurations. So that minimizes the confounding variables, obviously. Angiographic failure at 10 years was the primary endpoint. And I think this was good for them. If they put mortality, they would have had a primary outcome that was not significant. So it's a good thing that they decided to go with the angiographic failure, even though it didn't have any significant effects on outcome. So we can see here the graft failure, the RA versus the RETA. It's not important. On the right here is the SV versus the RA. And there was a significant graft failure with the saphenous vein, around 20%, as we could see in 10 years, and then around 13% for the radial. Again, just stick to the right side over here. This is the saphenous. This is mortality on top, and then on the bottom we have MACE, essentially, and we could see that there isn't really a significant difference between the two. So it's interesting, even though the patency was different, in terms of long-term survival, didn't matter. The 10-year patency rate of the RA is significantly higher than that of the free RETA and better than that of the SV. That was their conclusion. Another trial by this person here, Griefalt. So this is an 8-year follow-up, essentially. This is very well made, single center randomized trial, a good number of patients. There is a decent amount of blinding in the study. So let's go over it. So they took patients who had elective CABG for the first time, 3-vessel disease, and they gave each patient a LIRA, an RA, and a saphenous graft. So LIRA, Lima to the LAD, again, no problem with that. We have no issues with the Lima. And then essentially what they did was, after making the decision as to which coronary arteries they were gonna graft, they didn't reveal to them what they were gonna use to graft what until they were in the OR. So that was randomized as to which of the vessels that they were going to graft with the saphenous and the radial. The angiographic assessors were independent and blinded to the outcome of the randomization. So angiography was reported at 97 months. They actually had a 3-year result as well, which was also pro non-touch technique. So I forgot to mention this. So this was non-touch technique vein versus radial arc. So this is something that they've been working on a lot in Sweden, Brazil, China, a few other countries. So they're very passionate about this non-touch vein, and they were the early movers, really. of it, and that's probably why they're the ones that are studying it the most, because they were the first movers. They have the best studies, the longest studies with the largest outcomes and all that stuff. So this is the non-touch technique, and we're gonna talk about it. Just look at the results, and then we can talk about the non-touch technique. And essentially, it's a pedicle, just like we get the pedicle for the lima and the rima. We can get the pedicle for the vein. Maybe there is an increased risk of infection, however. These are the results for this. So graft patency for both the non-touch vein and the RA were high and similar, 86% versus 79%. So that's for the non-touch and the RA respectively. There's no significant difference between the graft patency. However, they found a significant difference between the patency of the coronary anastomosis grafted with the non-touch saphenous, and they found that it was higher than the RA grafts. And the conclusion was essentially that they have excellent patency, similar to RA grafts. This is the non-touch saphenous. And I guess one could also conclude that the saphenous is probably because of the randomization and the blinding that happened with which ones to anastomose. The saphenous is probably more versatile. We can use it for more grafts. That might be something that we can conclude from this study as well, which is a good thing, which is a benefit to the saphenous. These are all benefits. The next point I want to mention is the no touch technique showing superior results to the conventional. Obviously, you can see from the last RCT that I showed you that it probably will be, because if it's similar to the RA, then it must be better than the conventional saphenous. And really, we have a 16-year trial over here, randomized trial, Sweden again, published in 2015. And they had results at 1.5 years, 8.5 years, and then finally they had one at 16 years. And so primary aim was to examine the non-touch vein and the patencies versus the conventional vein grafts. And then the secondary aim was to compare it to the lima. And I don't support comparing it to lima because we shouldn't do that. We shouldn't be playing with fire, but that was their secondary objective. And so continuing is the conventionally harvested was obviously stripped from the surrounding tissue. This is the conventional one. And that causes spasms, it causes dilation, and then you have to dilate with the normal saline. And well, we all know how we deal with the saphenous and how we harvest it. It's obviously more rough. These were all open, so open convention. And these all cause vessel wall damage, stuff like that. The no-touch technique is harvested as a pedicle, keeping the surrounding tissue, keeping the fat around it. This has shown a lot of benefits on like a cellular level as well as a clinical level. And so the technique showed reduced risk of spasm and the need for dilation, because you have all the tissue holding it around, so you don't really need to dilate it as often as when you move the tissue around it. That's when the vein starts to spasm. That's why we have to dilate it more, so we can see it and so we can work on it properly. So it was a single center, 156 patients. They had 3 groups. They had a conventional, and then they had a saphenous, and then they had an intermediate group. And the intermediate group was not really a good idea. And this study was made a long time ago. Essentially, the intermediate group was stripped, just like the conventional, but it was not distended. They did not distend it with saline. So, I don't know. They didn't really follow them up. They realized it wasn't a good idea, and the patency rates were too low. They ended up essentially with 27 patients on the no-touch side and 27 patients on the conventional side. So as for angiographic follow-up, the conventional no-touch at a mean time of 16 years postoperatively. The first two follow-ups at 1.5 and 8.5 years were performed with conventional coronary angiography, and the third follow-up was performed using CT angiography. These are the techniques that they used. Over here we have the characteristics for the two groups. So over here we have, so as we said, 54 patients in total, 27. Saphenous patency was 64% in the conventional group versus 83% in the non-touch group, which was close to the Lima group, which was it's a fair patency. Let's not compare it to the Lima, but it's fair. 83% is fair for 16 years. The harvesting technique had a major impact on the patency, with a hazard ratio for inclusion of 1.83 for the C group. And we can see here in this plot here between the non-touch on the left, and then we have the conventional on the right. And the non-touch essentially was quite close to the Lima until the 16 year, where it deviated a little bit more compared to the conventional, of course, which was uncomparable to the Lima. Risk of wound complications was higher in the leg, where the vein was grafted from the thigh, and then we had an increase, obviously, in internal hyperplasia and atherosclerosis in the C grafts. And look at this graph, very nice graph. Pedicle hasn't been touched. It even looks more alive than those dead looking saphenous veins that we usually harvest. So the conclusion here, I mean, even the ones that we use right now are good. I'm just saying that there is room for improvement on this front, and shouldn't be discarded before we can try and attempt to improve those. So the conclusion was they had considerably reliable. It's a reliable conduit for cabbage, and the non-touch technique showed to be a good harvesting tool. And this was repeated again in China over here in 2019, and we have more studies that are coming out, all RCTs, a large number of patients showing good results. I think this one over here also had recurrence of angina was less than the non-touch group, and lower rates of inclusion. However, there were higher rates of wound surgical infections at 3 months follow-up, but after a year, they were similar. For the sake of time, I'm going to start sliding through. So improved patient quality of life, right? Angina, that's something. Other trials coming soon. We have the Swede graft trial. It's an RCT 900 patients. It'll be coming in 2023. Stay tuned. Non-touch versus conventional. And over here, I just have some pictures for the conventional versus the no-touch. These are post-mortem, the ones on the bottom. And then those ones that are fresh. This is just grafted. Additional factors supporting the non-touch. As we said, if we have the non-touch, we can preserve the perivascular fat tissue around it. It showed that this is actually superior in nitric oxide production. It keeps it somehow intact for a decent amount of time and helps the patency. Then now we have endoscopic non-touch saphenous vein grafts are now being studied as well. And this is, if this works, then the risk of infection goes down, and we can keep these similar patency rates, and that's going to be something really good for us. Over here we have a picture of the endoscopic, conventional versus no touch for endoscopic. Well, it's a pedicle. So the radial trial was a large, basically meta-analysis, and this is the only one that really that showed, you know, like a difference. I didn't bring it. I'm not going to talk about it, obviously, because that would be silly for me to talk about it. However, it's important to know that this was a meta-analysis, and this is, you know, it is exposed to bias, unlike an RCT, which is not. And that's why even the radial trial unfortunately wasn't able to seal the deal with it. And of course, there weren't really any non-touch saphenous vein graft papers in there. There were, maybe, I think there was one or two, but not enough. And so this, obviously, the non-touched, you know, the harvesting, we said over here, the post-mortem and the you could clearly see the differences. The vascular trauma, the distension with the inflating it. This all made a big difference. The endothelium there, when you keep it intact, relaxed, keep the adipose around it, it protects it, it keeps the nitric oxide more efficiently being produced in it. And this is funny, but this is really what it is. This is how we handle our saphenous vein grafts versus how we handle our arterial grafts. So even after we've grafted them, there's a big difference. So before we spend 20 years making large RCTs, let's try to go easy on the grafts first. I actually didn't have, I saw this, I didn't want to mention it, but then when Walid mentioned it, I decided to include a picture. This is the external support for the saphenous vein. It's still being studied. The result, however, I don't know what I don't know. I'm not sure what Walid what he read about the results, or maybe I was reading a different study, but it didn't really show anything when they accounted for all the variables and the co-founders and whatnot. It didn't really show to be that beneficial. So that's just to touch on that for anybody that was curious. And the guidelines are talking about the no-touch technique. The European guidelines have recommended it's class 2A, so that's good. And then, well, the Europeans have, the Swedish have invested a lot in this. Maybe that's why they're more lenient in including it. The American, but it is a class 2A recommendation, and that is something for it. That's something to keep an eye on, because that 2A maybe one day will become a 1A. For the American guidelines, they haven't really included it the way that the Europeans have. However, they have mentioned it in their best practices in their 2021 guidelines, and that's a step that shows that people are now seeing it. And so the point is, to summarize, no real RCTs between the radial and the saphenous showing real benefits, quality of life, mortality, whatever. BEMA hasn't been effective. We can see that versus SEMA. Let's see what the Roma trial says. But as far as it goes now, it seems like the vein graft has a lot of room to improve, and could reach a point where we don't need to think about being invasive with these arteries and stick to something that is simpler, that's easier to use, that gives us more length, that has just been with us from the beginning, and maybe we should stick to it, stick to the saphenous and the lima, and forget about the radial. So that's the end of my presentation.
Thank you, Abdelkarim, for your informative presentation. And we doesn't do it in daily practice. You just initiate a new point for us. Thank you, Abdelkarim. Is there any question, Dr. Hussein Al-Amoudi? You want to add anything?
Thank you for both presenters, Faris and Abdelkarim. They did an excellent job. Faris or Faris?
Faris.
Faris. So they both presented basically the landmark trials. They did a lot of work, everybody to support his argument, which is amazing. I see that no one left. All the participants are available to basically hear and see what the most important part of this is basically a review for all the residents that there are lots of evidence to support each one of them. And then when I asked Abdul Karim, why did you take the vein? He said, this is what they gave me. I said, okay, that's fine. So it's good that there are lots of nowadays debate about subgroup analysis from the ART trial and other trials, seeing if this, for example, REMA is, especially the skeletonized one, effective or no. And I did hear a debate about this in the last EACTS conference from, I forget the name I forget the name of one of the main surgeons in McMaster University. And he discussed this with one of the surgeons also from the States, and there was a nice debate about with both supporting like using Lima versus using bilateral Lima or bilateral with what the second can do it. But the most important part is the biggest trial that's gonna answer all these questions, and because there was no big randomized trial comparing each one which is the best second conduit, and it's going to come from Toronto in the next few years, probably around 2026. They want to basically finish everything, and then we will have the right answers. What is the second best conduit? I just would like to congratulate both of the residents for supporting their argument. I have my opinion, but at the end of the day, patients are different, and the circumstances in the OR are different sometimes, and the help that you have at that time and the urgency of the surgery plays an important role, and how young the patient is, and how long the arm is, and how good the test, Allen's test or ultrasound to see. I mean, there are lots of factors to which one to choose, but at the end of the day, the main purpose of this debate is basically have more information to everybody, and then we as surgeons individualize the patients and choose what is best. But the common practice in the young people is probably more arterial, if possible, and without any compromise. And for people who are a little bit older, the vein is good, but I've never seen lots of no-touch technique used. I've never used it myself because it needs probably more experience. Some people who basically who are able to do it all the time, but it is very promising. If that will be done safely, then it is a good second conduit, specifically if there are any limitations on the other arterial conduits. Thank you both.
Thank you, Dr. Hussein Al-Amoudi. Thank you. Any question? Okay, Dr. Mariam Al-Umair, is it suitable for you to start after 5 minutes?
Yes, absolutely, no problem.
Inshallah. Thank you, Abdul Karim.
You're welcome. Thank you.
Dr. Maria?
Yes.
Yeah, we can start, inshallah.
Okay, welcome everybody. Today we're going to talk about acute coronary syndrome cases. I prepared 2 quick cases, again, targeted for the R7. So I would ask if we have any available, if any R7 is available, to raise their hand. Okay, we have Rasha and Zainab and Khalifa. Okay, we can start with Rasha.
Yes, sure, Doctor.
Okay. All right. Okay, case number 1. This is the case. You can read the scenario.
Okay, 55 years old male presented with acute chest pain, diaphoresis, and palpitation. He was seen in the ER, and here is the ECG.
Okay. Can you read ECG? Any finding?
Yes, there is ST elevation in the AVR, AVL, and also in the V4 and the V6 also. This looks like a anterior STEMI.
Okay, so where exactly you see the most significant ST elevation?
From V4 to V6.
From V4 to V6?
Yes, but also AVR.
Okay, so if I point here, do you see any ST elevation here in V6?
Oops. There is here ST elevation, yes.
ST elevation?
Here, right?
Okay, so if you compare the ST elevation in V6 to the ST elevation in V2, what do you think is more significant?
I mean, if V2 is more significant, of course.
Yeah, so the most prominent ST elevation, you can notice it in V2,
yeah.
V3, V4. It starts to settle down in V6 and V5 and V6. It's not that prominent. Okay, and you said you're concerned about anterior STEMI?
Yes, maybe.
Okay, okay, sounds good. And which, like, based on which lead you will classify your STEMI? Like, how would you say this is anterior STEMI versus inferior?
Okay, so inferior STEMI is 2, 3, and AV1.
2, 3, and
AV 2, 3, and AV 2, 3, and AVL, I guess.
AVL?
It's 2, 3, and AVR.
Yeah. For inferior
right?
STEMI, for inferior STEMI is basically 2, 3, and AVF. Okay, and
okay.
And then you would have ST elevation and those prominent ST elevation and those lead. How about an anterior STEMI?
So the ST elevation in the anterior STEMI will be V1, 2, and the 3.
Okay, how about V5 and 6?
Yes, also V5 and 6.
It's anterior STEMI?
It's a lateral.
Okay, so what's your diagnosis here?
So it will be, as we said, it's 2 and 6, so it will be anterior.
Okay, so it is acute MI, right? So
yes.
It's STEMI. And what is your suspected territory here?
As we said, it's more prominent in 4 and 2, so it will be anterior.
Which artery you think it's mainly affected?
LAD.
Okay. How would you medically optimize this patient? This patient had presented with STEMI, acute MI, based on the ACG. So what would be your initial management for this patient?
So first of all, the patient should be on Tridane infusion to dilate the coronary and the
What is the infusion? So I didn't hear you. What's the infusion?
What? Tridane?
I can't, sorry, I can't hear you.
Is my voice is clear now?
Yes.
So first of all, we're going to start with the Trideal infusion for the dilation of the coronary. And then we can put the patient on heparin also. If he came with within the acute period, he might go for thrombolytic therapy as well if there is no contraindication for that. Also analgesics like morphine for sedation of the patient, and then we can send the patient for CAT.
So I agree with most of your, medical management. Again, you want to make to optimize the patient, take vitals, and make sure the patient is stable. Start with pain medication. IV morphine is usually preferred, and the guidelines. Oxygen supply, if oxygen saturation is at 90%. And then the first drug you're going to give this patient is?
Trideal for the or heparin.
I still can't understand what's this medication. Can you type it in the chat? So just so.
Okay. So the first drug is heparin. You can hear me, right?
Yes. Yes.
You want me to type it?
Just the medication that you said, the IV infusion. To dilate the coronary. You said you're gonna, yeah. What is it? Can you type it? Because I still can't understand it.
Okay, just okay. Yes.
What is the pharmacological name of it? Do you know? This is most likely it's the trade name, right?
Yes. So you want the generic name of the?
Yeah, I'm not aware of this medication probably because
the nitroglycerin. It's a nitroglycerin.
Okay, nitroglycerin. Okay,
yes.
Sounds good. All right. Yeah. So the first medication we're gonna give this patient is aspirin. Okay.
Okay.
This is the first medication. Like if you have any suspicious of acute MI and any patient with chest pain, the first thing we can give him is aspirin. Okay. And what's the dose? Do you know the dose of the aspirin that you should
300
recommend? Yeah, so it's a range from 162 to 325. It's different from the baby aspirin that we usually give after the insult. Okay, and then of course the patient in the emergency department, then you would optimize the patient as we said, and you will start IV heparin, which is usually unfractionated heparin, and you will load this patient with
Plavix.
Plavix to send him for the cath lab. Do you know the dose for the loading Plavix?
600.
Yes. Do you have any other options
other than the Plavix? Like another antiplatelets medication?
Correct. Yes.
I don't know.
Okay, so there's Plavix, there's Ticagrelor, there's Prasugrel. Have you heard of them?
Okay. Yes.
Yeah. Okay, and each of them has a different dose for loading and maintenance dose. So I think you should, in general, you should know different doses. Okay.
Okay.
All right, we'll go next. This is the angiogram for this patient. So it was sent to the cath lab. Let me know if you want me to go back.
Maybe you can stop here.
Okay.
No, not the other view. Yes, this view. Okay. You can stop here, please. Okay.
Okay, what's your finding? Probably it's just going to keep saying the same view over and over.
Okay, so the RCA is normal. I couldn't see any lesions. The LCX, there is, I think, proximal, but I don't think it's significant, or maybe mid at the bifurcation. The LAD is, I cannot appreciate the LAD very much, but can see again. Left main is normal also. I think there is a proximal LAD lesion.
Okay.
And that's all. Maybe diagonal as well, but I cannot also comment on the diagonal from this view.
Okay. So is that where would you expect the lesion?
Yes.
Okay. All right. Does the information or the ECG finding goes along with the angiogram?
Yes.
Okay, which is confirmed.
Confirm a proximal LAD territory that goes anterior STEMI.
Okay. How would you manage this patient, PCI or CABG?
According to the guideline, proximal LAD is class 2B indication for CABG and PCI together. So maybe it's one vessel disease, so maybe he can go for PCI.
Okay. Okay. I mean, would you frame your answer according to the situation?
Yes.
Or I will just make it more clear. So this patient is presented with acute STEMI.
Okay.
Right. So what are the indications for coronary bypass surgery and acute STEMI?
If the patient is hemodynamic unstable, or he is in cardiogenic shock, or if he is a failed PCI, or in heart failure, or cannot be optimized medically.
Okay, so I agree with you, and you're just missing one important indication.
I missed one important indication?
Yeah, yeah. Mechanical complication of MI. It's an class 1 indication for bypass. So in general, the rule of coronary bypass surgery in STEMI or acute MI is very limited. Okay, most of the patients will go to the cath lab immediately after STEMI, and they will be the major or carpet region will be stented. Okay, and this is the gold standard for guidelines. It's class 1 indication for PCI. There is no rule for CABG and acute STEMI unless those 4 indications you mentioned: patient with mechanical complication of MI, patient with arrhythmia that is thought to be related to ischemia, patient failed PCI, or PCI is not available, or patient in cardiogenic shock. Okay. Even patient with cardiogenic shock, there is a debate of whether you should go and see the patient quicker. If you think the PCI can be done quicker and safer, and you can stent the vessel, the guidelines will favor PCI over CABG. Okay, so in general, this patient, we agree that should go for
PCI.
PCI. Okay, if I tell you this patient is diabetic and has 3 vessel disease plus the culprit region, which is the proximal LAD, and the initial angiogram that was done for him, how would this change your management or approach?
So now the perspective of the patient has been changed. A 3 vessel disease plus a proximal LAD is an indication for CABG according to the recent guideline. So we should take this patient for not emergency cases after optimizing the patient medically, like for 1 week, then we can offer him a CABG.
Okay. So that was a very tricky question. Okay. Again, I would say patient with STEMI, there is no rule for coronary bypass surgery unless they have the other 4 indications that you mentioned. So Rasha, you understand the indication for CABG and STEMI. So don't be confused. Even if the patient is diabetic and has 3 vessel disease plus the culprit, the main reason or the main situation here is the patient has acute MI. So you want to establish flow to that target as soon as possible. Okay.
So we do
again,
PCI and then we offer him CABG or what?
So you do PCI to the culprit region. Okay. So if you think according to the ECG, is the LAD is a culprit region, even that he had another coronary disease. The main goal is to open the LAD and stent it. And then you can talk about the other disease, the other coronary artery disease. You can stabilize the patient, discharge him home, and bring him back for elective CABG later. Okay. So, or you can also operate within sometimes the same hospitalization of the patient having ongoing angina to reopen the other vessel, because the other vessels are chronic and they're not causing acute symptoms. Okay, so it's very important to understand again the rule. There's no rule for coronary bypass surgery or CABG in a patient with STEMI. Even if he had multiple vessel coronary artery disease, has diabetes, no matter what, then the class 1 indication is to do a PCI and to open the culprit region. Okay. Now the arguments come with if you are in the cath lab and you're opening the LAD and stenting. So the cardiologist, interventional cardiologist will be like, maybe I can stent the other vessel. So how can you argue, or what would be your approach? Would you agree or disagree?
Well, depend on the vessel status. If it's a single lesion on maybe 2 vessels or 3 vessels, single lesion that can be stented, and it's the patient is diabetic, so maybe it is an option. But even though according to the guidelines, so 3 vessels, the proximal LAD is always a class 1 indication for CABG. So that's what my answer will be to the cardiologist. Okay.
So I will just emphasize that there's different guidelines, and what we have discussed before, it was a stable ischemic heart disease. Okay. And those are where the guidelines will come from, that you'd have, there's a coronary or CABG class 1 indication if the patient has left main, if he had, for example, 3 vessel disease, or has a proximal LAD plus other vessel. This is a stable coronary artery disease. It's a different category or different population than patient with STEMI. Okay, so we need to manage this patient differently. So the indication for coronary bypass in acute STEMI patient, I'm sorry, I'm in clinic and they're trying to close, but it's okay. All right, so yeah, what I'm saying is you have to understand there's 2 different guidelines, stable ischemic heart disease, and their guidelines and recommendations is completely different than patient with acute MI. Okay.
Yes.
So now the debate, are you aware of any recommendation for a patient with like stenting other vessels beside the culprit region, a patient with acute STEMI?
So you're asking about the guideline for the CABG and the okay. So as we know, it's class 1 indication is a as we said, emergency CABG like failed PCI or mechanical complication or vaginal shock. Class 2A indication is if the primary reperfusion within 62 hours is not suitable or failed PCI. So, and if the patient is suitable for coronary arteries and the lesions are significant in 3 vessel disease, so I think CABG is more prior to PCI.
Okay, I'm just gonna rephrase my question to you, Rasha. I mean, this patient now has acute STEMI, okay? And we know the culprit lesion is the LAD. And they're now in the cath lab and they have stented the LAD and they re-established the flow to that vessel, okay? Now they're looking at the other vessel, which is the RCA and, for example, O1, and they're wondering if they should stent them while they're in the cath lab or if they should stop at this time. So I'm just asking if you're aware of any recommendation regarding this situation.
In the acute STEMI, I guess I don't remember any recommendation in the STEMI to if they can stent it. I think they can, but I don't remember any specific recommendation for this.
Okay, so I'll tell you, I'll guide you through this. There is a recommendation, and AHA recommendation is used to be class 3, which is harm or no benefit of opening or the other vessel other than the culprit lesion during STEMI if the patient is in a shock. Okay, so this is the guidelines. You should not, or you should only deal with the culprit lesion in a patient with a STEMI if the patient is unstable. It's a class 3 indication. Okay, now the other debate is how about if the patient is stable. Okay, again, it used to be same class 3 indication that they should not open the other vessel and they should only stick to the culprit lesion until 2015. In 2015, they did a study. It's called complete trial. Okay, the complete trial, they randomize or compare between 2 groups: patient with STEMI, and they're all stable patients. They're not in shock. So patient with a STEMI, and they stented the culprit lesion plus the other, versus stenting only the culprit lesion. And what they found, actually, there is a survival benefit for complete revascularization in a stable patient. As such, the guidelines in 2015, there was an update for AHA guideline. I think there's only 3 pages of the update to reflect that trial. So they changed it from class 3 to class 2B in a stable patient. However, if the patient is unstable, it is still class 3 indication. So you should only stick to the culprit lesion and not touch the others.
Okay.
Okay, the two article or the 2 trials is the culprit shock trial, which investigate loose opening or complete revascularization versus culprit lesion only in a patient with a shock, and there was significant increase of mortality if you would do complete revascularization at the primary PCI. The second trial was the completed trial, and it is the opposite patient. It's patients with a STEMI, however, they are stable, and they found there's improved survival with complete revascularization at the primary PCI compared to culprit lesion only. Okay.
Okay. Okay.
All right. And then I asked you earlier what was the class 1 indication for CABG with STEMI, and this is just to re-emphasize again, our limit or our job or rules as a cardiac surgeon in acute STEMI is very limited. Very few patients will present it to us to operate on while they have acute STEMI. Only if they have as we mentioned, mechanical complication, if they have arrhythmia, if the PCI has failed or PCI is not available. Otherwise, it's a class 1 indication to be referred for primary PCI. Okay, I think this is the first case. It's very well, Rasha. Thank you.
Thank you.
Any comments or any question related to the case?
Dr. Mariam, Assalamu alaikum. Yeah. Can we go back to the cath for the proximal LAD lesion?
Mm-hmm.
Yeah. Can we call that a proximal coronary artery dissection or just a lesion?
Yeah, I know this case. It's a real case. So it wasn't a dissection. It was acute STEMI, but it raised the concern of SCAD. I totally agree with you because it doesn't feel normal. However, you don't see any extravasation or any dye outside the contour of the vessel.
Okay.
But this is the typical of acute MI, you know, when the plaque ruptured. We probably don't see much of this coronary angiogram. We see more of the stable coronary artery disease patient as referred to surgery. So we don't see those type of angio very often. This is
Okay.
a typical, you know, ruptured of plaque.
It gave me the SCAD features.
Yeah, I totally agree with you. It's very concerning.
Thank you.
Any other question regarding to the case?
Yes, Assalamu alaikum, Dr. Mariam. I have one kind question here, actually, about the same indication about emergency CABG. Like you said, it's STEMI, the rule of CABG and STEMI, it's really limited. Yani. Left main can be one of the indication for the emergency.
Yeah. So again, for the indication, there's a specific indication. For left main, there is no class 1 indication, either for PCI or CABG. Okay, it's both class 2 indication for PCI, class 2 indication for CABG. However, they will tell you it's class 2 indication to favor PCI over CABG if you think the PCI can be done faster and achieve restore the flow to the coronary in a more stable fashion. So again, so there is no absolute class 1 indication in this type of patient, but they will still prefer PCI over CABG, giving the rapid, you know, establishment of the flow and the coronary.
Okay, thank you so much.
Okay. So again, I just want to emphasize again, it might be a little bit confusing while you're reading the guidelines. I know you all will all stick to the, you know, left main visual disease, proximal LAD is a class 1 indication for coronary bypass, but keep in mind this is in a stable ischemic heart disease, but not STEMI. Okay. Okay. So case number 2. Do we have any volunteer?
أيوة دكتورة.
Who's talking? Sorry.
زينب.
Zainab. Okay. All right. Go ahead, Zainab. Read your scenario.
So this is a 74 years old female presented with a STEMI diagnosed in a field by EMS, past medical history, ischemic stroke 2 months ago, with no neurological deficit, controlled diabetes and hypertension. Here's the ECG.
Can you comment on the ECG?
ECG, I can see ST segment elevation on lead 3 and ST segment depression in the AVL and 1.
Okay. What's your diagnosis here?
It's an acute coronary syndrome on the lateral lead, 1 and AVL.
1 and AVL. Acute coronary syndrome, okay.
This is ST segment depression.
Okay, so you have ST segment elevation and you have ST segment depression, right?
Yeah.
Yeah, so okay, so is this an STEMI and you will go with the ST elevation? Or is this angina and you will go with the ST depression?
No, it can be like ST segment elevation with reciprocal changes on the other leads.
Excellent. So if you have ST elevation and you said in lead 3?
Yeah.
Yeah, and lead 3 and?
2 and AVF. It's
so 2, 3 and AVF.
Inferior lead.
Yes, which is, it goes with the inferior MI. And where's the ST depression?
I can see it in lead 1 and the AVL.
Is it expected to have ST depression in lead 1 and AVL?
Sorry?
Is it expected to have a ST depression in lead 1 and AVL?
Is it expected?
Yes. Do you expect this or no?
I'm not
sure. Is it normal to have those ST depression?
In normal people, no.
Okay, but in this case?
I'm not 100% sure.
You mentioned it, you said there's reciprocal changes, right? And it's normal with the ST elevation that you would have a mirror image, ST depression, and the other lead, right?
Mm-hmm.
and acute STEMI. So you shouldn't be surprised. You should look for those. If you see only ST elevation, let's say you can ST elevation, one of the differential that will differentiate localized pericarditis. You know, pericarditis will present with diffuse ST elevation, right?
Yes.
Post surgery. Sometimes you see localized pericarditis, and you can see like ST elevation and not all the lead, but specific leads. Okay. The way to differentiate if this is a localized pericarditis versus acute STEMI is to look for the reciprocal changes. If you don't see them, that means this is a pericarditis. So this is one of the assuring things that you can, if they called you overnight for a patient with ST elevation and you come and see, you see, for example, ST elevation in a few leads, but you don't see the reciprocal changes, one of the reassuring things, of course, you're going to order troponin and you're going to check for the ECG again, you'll see the clinical status for the patient and everything. But one of the reassuring things that might not be an STEMI. Okay.
Okay.
Okay. So what was your diagnosis here? You said inferior STEMI.
Yeah. And
what is the suspected territory?
RCA. PDA RCA.
Okay. You made the right. Okay. The nearest piece. This patient was seen by EMS. Okay, by ambulance. The nearest PCI facilities is 70 minutes away. What are the options for this patient, and what's your recommendation?
So we have first medical contact to the needle, which is 60 minutes, and then to PCI 90 minutes.
Okay. First medical contact to the door of the cath should be?
It's like door to balloon and door to needle. Door to needle is 60 minutes and door to balloon 90 minutes.
Okay, so this patient is 70 minutes away from the PCI. What do you want to do?
So
what are the options to treat STEMI?
We have fibrinolytic therapy.
Okay.
And
or primary PCI, right? Yes. So if I tell you from the ambulance till the PCI facility, it is 70 minutes till you reach the cath lab. Okay.
So yeah,
which is to the balloon, 70 minutes. Would you send this patient to a PCI facilities, or you're gonna do fibrinolysis?
70 minutes is less than 90 minutes. So
90?
Yeah, PCI.
PCI. Okay. How about if more than 120 minutes?
Then fibrinolytic therapy, like altiplate. Okay.
Do you know any contraindication for fibrinolytic therapy?
Recent intracranial hemorrhage, bleeding diaphysis, like brain tumor. These are what I'm thinking about right now.
Do you remember the patient's history?
She has a stroke, recent stroke, like 2 months ago.
Do you think this is a contraindication to fibrinolytic therapy?
I'm not sure if it's mentioned ischemic or hemorrhagic. So ischemic. I think there is risk of hemorrhagic transformation, but I'm not 100% sure. I'm not sure if it's like 2 months is the cutoff for the hemorrhagic transformation.
Okay, so from the indication or contraindication, if the patient has ischemic stroke 3 months ago, less than 3 months is contraindicated, more than 3 months is not contraindicated. The risk of hemorrhagic transformation usually is higher with acute stroke, not 2 months after. Okay, but again, you have to know the absolute contraindication for fibrinolytic therapy, which you mentioned most of them. Okay, this patient was sent actually for to the cath lab, and this is her angiogram.
So I can see this is the right coronary infection. I can see like mid segment stenosis. The PDA is like patent. It's not. I cannot see any. There is a collateral flow to the. And then this is left system.
What do you think about the left main? What do you think about the LAD?
Left main, I don't see any significant disease, but the LAD, there is, I think it's from med, in the med, I can see significant stenosis, and then in the distal part, it's like, it's totally occluded.
Okay. Yes, I agree with you. How about the circumflex? Any disease in the circumflex?
Circumflex, honestly, ostial circ, ostial OM.
Okay.
First OM.
Yeah, here, right? Okay, so is the finding of the angiogram is consistent with the ECG finding?
Yeah, the RCA is stenosis, but the other maybe chronic.
Yeah, the patient has a chronic LAD disease and a chronic occlusion and has formed some collateralization with the RCA. When the patient has occlusion or stenosis in the RCA, the patient presented with STEMI, because basically the RCA is also collateralizing the LAD, so it's affecting everything, not only the right system, but also the left system, because it's collateralizing with the LAD. Right? Okay.
Yes.
So this patient actually underwent successful fibrinolytic therapy, just to complicate the story, okay? It's not because it's, I know it was within 90 minutes and patient had coronary angiogram, but just like to make the scenario a bit more complex. So this patient underwent successful fibrinolytic therapy, okay? Are there any indication for PCI after initial fibrinolytic therapy? Or how do you manage this patient?
So it is successful fibrinolytic therapy. So rescue PCI and these things is out of picture. So we have now transformed this patient from like STEMI to stable coronary artery disease. So I would manage this patient if there is no like chest pain, which is ruled out by successful fibrinolytic therapy. I would manage this patient according to the guideline of stable coronary artery disease.
So you're saying there is no indication for PCI. So basically you're gonna optimize this patient medically and discharge him home and then bring him back for elective surgery to address the other territories or the other coronaries?
Yes.
Okay. So there is actually a rule for PCI even after successful fibrinolytic therapy, and you should be aware of this. And it is the class 2 indication to refer this patient to a PCI within 24 hours after successful fibrinolytic therapy. Okay, the same guidelines, the same recommendations, class 2 indication to send this patient for primary PCI after failed fibrinolytic therapy. So this is just only a temporary measure to trying to reestablish flow through that disease coronary. However, you have to send this patient for PCI, and they usually stent them.
Okay.
Okay. Now the debate is the same whether you should stent the other, the LAD and the OM, for example, or you should refer this patient for bypass. Again, as we mentioned, the patient now is stable, so it's the recommendation is the class 2B that you can stent the other, but it's class 2A as the patient is now considered to be stable ischemic heart disease, that you should refer him for an optimal heart center for evaluation, for which to decide whether this patient is a best candidate for coronary bypass versus a PCI. Okay, so you'll look into the target, you'll look into the clinical scenario of the patient, if he had diabetes, if there is left main involvement or not, all those the syntax score to see whether coronary bypass is favorable or not. Okay. Okay, so now I would ask you about the antiplatelet therapy duration in this case versus if this patient underwent primary PCI.
So for primary PCI, it will be dual antiplatelets for 1 year, and then aspirin for life. And fibrinolytic therapy, I'm not sure. I think it should be the same.
Okay. How about if this patient underwent CABG for whatever reason? He was not treated with PCI, but was referred for emergency CABG.
I'm not 100% sure about the class of recommendation, but I know that CABG post-acute coronary syndrome, patient should be on dual antiplatelet therapy.
For how long?
Same as primary PCI.
Again, don't be tricked with the questions. The recommendation for dual antiplatelet therapy in patients with acute coronary syndrome, it's 1 year dual antiplatelet therapy, regardless of the method of revascularization. Okay, either fibrinolytic therapy, PCI, or CABG, still you're gonna keep this patient in dual antiplatelet therapy for 1 year, and then you switch to aspirin. Okay, and there is a class 2B indication to actually, if the patient that had low risk of the bleeding and stuff, you continue dual antiplatelet.
Okay.
What do you think about aspirin plus Plavix versus aspirin, ticagrelor, or prasugrel post PCI and patient with acute coronary syndrome?
So I heard about aspirin and ticagrelor in the recently have changed. The recommendation have changed from aspirin to Plavix to ticagrelor. I'm not 100% sure about what changed, but recently they are doing like aspirin and ticagrelor for acute coronary syndrome.
Okay, so if you operate on a patient with NSTEMI, okay, I presented not with STEMI and STEMI, and he was referred for surgery, and you did a CABG time 3 on him. It was very successful operation, and then in our practices, a nurse practitioner, but here, for example, the junior resident who's preparing this patient for discharge called you and said, do you have any preference, doctor, for dual antiplatelet in this patient? You want me to keep him in aspirin Plavix or aspirin ticagrelor or aspirin prasugrel? This patient post CABG.
Usually we put aspirin and Plavix, but
in the center you're practicing, what do you discharge the patient on?
Aspirin and Plavix.
Aspirin Plavix. Okay, sounds good. So you said like you have the practice has been changed and more people favorable now aspirin ticagrelor. Do you know in which situation? Do you think it's mainly post PCI or post CABG or any specific indication?
I think it's in PCI.
Okay,
but
Go ahead.
So I haven't read anything about it, but I heard about it.
Okay, so there is actually lots of randomized control trials comparing dual antiplatelet in terms of aspirin Plavix versus aspirin ticagrelor, and the study it calls a PLATO study, PLATO, in patients with acute coronary syndrome. Either they underwent PCI or emergency CABG or fibrinolytic therapy. They noticed there's an increase in survival and decrease of repeat revascularization and preoperative MI in patients who had ticagrelor over Plavix. Okay, the other things that we're looking and that we're concerned about, the increased risk of major bleeding. There was no difference in risk of major bleeding for this group who received aspirin Plavix versus aspirin ticagrelor. So the conclusion is aspirin ticagrelor is preferred as a combination over aspirin Plavix to improve survival. It's not only, it's to improve survival. So if you have a patient with acute coronary syndrome, either STEMI, NSTEMI, or unstable angina, if you want to do a good for this patient, you have to prescribe an aspirin and ticagrelor over Plavix. Okay, and it's actually has made it to the guidelines to class 2A indication. Okay. They did a similar study to compare aspirin Plavix versus aspirin Prasugrel, and they found the same conclusion. Aspirin Prasugrel has a survival benefit over aspirin Plavix. However, patients with in the group of aspirin Prasugrel have increased risk of not major bleeding, but procedure-related bleeding over aspirin Plavix. So in general, guidelines are class 2A to use ticagrelor or prasugrel over Plavix in acute coronary syndrome, regardless of the method of revascularization. Okay, you should just be aware of this information. Okay. Okay, so was the end of the case. I just have a few things about, I just noticed that my 2 cases were about acute STEMI, because I noticed that if I would go into details into the procedure and coronary bypass, I thought we have covered that in the last few sessions, the conduit use, the complication during the surgery and stuff. So I wanted to highlight the management of patients with acute coronary syndrome. And yes, we are surgeons and we're always advocate for coronary bypass surgery. However, in patients with STEMI, the best practice is to refer them to an urgent PCI. Okay. Now, if you have an NSTEMI patient, which is non-STEMI, or unstable angina, which is still part of acute coronary syndrome, their management is completely different than those patients with acute STEMI. And they have a different guidelines. Okay, STEMI guideline is different, and STEMI and unstable angina is different. And you have to differentiate the difference in the management. Medical management is the same. You will optimize this patient, give them aspirin, start IV heparin, and then to see whether this patient need urgent cath or not. Immediate PCI for NSTEMI patients only indicated in patients if he's unstable or had refractory angina or continuous chest pain despite the medical optimization. Okay, this is the only indication to send the patient from the emergency department to the cath lab if he had NSTEMI. However, if he had NSTEMI but he's more stable, then you would do either early invasive PCI, which is within 24 hours, but not urgent. He can go to the floor or to the CCU, medically optimize, and then we can send him for cath within 24 hours. Those patients, I'm sorry again for the interruption. Okay, so this patient with early invasive PCI within 24 hours is actually those patients who had high risk comorbidities, high troponin, but patient is stable, extensive risk factor, or you have some scores that you can use to classify or stratify the patient. One of them is a GRACE score, and if it's more than 140, it will put this patient into this category, and you would advocate to send this patient for PCI within 24 hours. Basically, the GRACE score, it usually looks at the patient's age, the comorbidities, whether has a diabetes or not, renal failure, hypertension, stuff like that. And the more risk factor, the higher the score will be. Okay. And then if you have a patient, we can refer another type of patient with NSTEMI to a delayed invasive, which is a PCI within 72 hours, within the hospitalization, but not urgent. If they have previous CABG, if they have previous PCI, the presence of diabetes mellitus, it's an indication to send this patient for PCI within hospitalization. If the GRACE score is between 100 and 140, or the TIMI score is more than 2. Okay. If you don't have none of these, let's say his Grace score is less than 100, TIMI score is less than 2, the patient doesn't have diabetes, never had non-coronary artery disease before, troponin is not that elevated, he's not having angina, or patient is completely stable, then you would do ischemia-guided therapy. Anybody knows what's ischemia-guided therapy? Any volunteer? Have you ever heard of this term? Okay, so ischemia-guided therapy basically is in those patients who's stable as Grace, it's actually to refer them to non-invasive testing. So you're just gonna optimally, medically optimize them, and then you're gonna discharge them and bring them back later for example, treadmill or D-vitamin stress test, and then you'll stratify whether they're a high-risk coronary artery disease or not. Okay, so I just want to give you a brief of how to manage those patients. Which patient that you will rush to the PCI, patient with a STEMI, no questions. However, patient with NSTEMI, you would see how there's different categories. Patient could be referred directly to PCI. You could call the PCI people and said, we have to send this patient to the PCI urgently. This patient has NSTEMI and he's unstable or he has refractory angina. However, you can wait 24 hours or 72 hours, or you can not refer him to a PCI, just like medically optimize them and refer him for non-invasive testing. Okay, in general, NSTEMI patient, PCI versus CABG, they have similar indication to stable patients, stable coronary artery disease. Meaning if they have left main, if they have reverted disease, proximal RAD, they will favor CABG over PCI. This is not the case with patients with STEMI, where they will favor PCI over CABG, except on certain indication. Okay, so this is the end of my presentation and my cases. I hope you guys have learned something. I know sometimes that might be confusing. Our next section will be about a mechanical complication post-MI, which is going to be next week. I'll prepare a few cases. In the meantime, if you guys have any questions, please let me know.
I have a question, Doctora.
Yes.
You said regarding the recommendation of aspirin plus Plavix and aspirin plus ticagrelor over aspirin plus Plavix. Is it only in acute coronary, or the same recommendation goes for post-CABG and post a stable elective PCI?
Very excellent question. Those studies were done in acute coronary syndrome patient. So the benefit of aspirin plus ticagrelor in a stable patient is it's unknown, but they're reflecting that it might be the same. If you're seeing survival benefit in acute coronary syndrome, you may see it also in stable patients. So in general, we use right now most of the patient aspirin, ticagrelor, even in a stable patient. But the guidelines and the studies were including only acute coronary syndrome patients.
Thank you, Dr. Mariam Al-Umair. Is there any more question?
Dr. Mariam, so في الSTEMI, when you read like timing for CABG and STEMI, they usually talk about like within 6 hours. It should be done within 6 hours from the onset of the symptoms, and which will improve the mortality will be reduced comparing when it's done like after 24 hours, and the lower mortality will be if it's done more than 8 days. So in patient with if we see the guideline CABG will be done for specific type of patient where they are like very having like a cardiogenic shock, or they have ventricular arrhythmia. In this kind of patient, they cannot wait for 8 days, or the ventricular arrhythmia or the cardiogenic shock, it will be maybe presented more than 6 hours after symptoms, which is the chest pain. So how can we go around this one?
So this is a very, who's talking? Is it Zainab?
Yes.
Yeah, this is a very excellent question, and it's always been a bit debatable. And I was planning to mention this and discuss it, but I completely forgot. Yes, if you have to operate in a patient with a STEMI, the data showed that you would have a survival benefit or less mortality, preoperative mortality, if you operate within the first 6 hours within the STEMI. After from 6 to 12 hours, the mortality will increase from 4% to 20%. This is an observational study, okay? If you operate after 24 hours, the mortality will decrease from 20 to 10, but still high, it's 10%. If you operate after the second day, it will decrease to 7%. If you operate after 4 days, it will decrease to 3%. And if you operate after 8 days, they said the operative mortality should be similar to patient with a stable ischemic heart disease, like elective patient, which should be less than 2%. Okay, why? It's basically because of the inflammation happening around the ischemia or infarcted area. So it's one, it increased the technical difficulty to do your anastomosis, because sometimes if you would do it in an inflamed artery, your suture may rip through and you make your anastomosis more difficult. So it increased the preoperative MI and increased the mortality of the patient. Now, to answer your question is when to advocate. I know in some situation you can't argue. If you need to go for the OR right now, you will go, especially patient with arrhythmia. However, the debate here for patient with mechanical complication of MI, and this I'm going to touch base on it next week. But if you have patients with, for example, VSD, for example, ventricular defect post-MI, okay, and he presented with acute STEMI, and in the angiogram or the echo, they showed there is a ventricular septal defect. Now, and they referred him for surgery. Now, your argument would be, can I, and it's been like, for example, more than 6 hours since the MI. So your answer will be, can I medically optimize this patient, put him an intra-aortic balloon pump, and wait for at least 2 to 3 days before I operate, just to enhance the tissue, this edema, this inflammation around the coronary, to make my my surgery better and to decrease the risk of a preoperative mortality? Now, if you can wait, it would be great. Most of the cases, the patient will be hemodynamically unstable. You'll put intra-aortic balloon pump, you'll try to stabilize him, and he will still have severe pulmonary edema. You'll put him in Lasix infusion, and he will still won't be that stable. So at this point, you have no option other than taking him to the OR immediately. Now, if you heard about this case of consultation in the cath lab, and you think that they're going to consult you as a surgeon, run. Go to the cath lab, see this patient, and tell him, I need to take this patient, if this is a surgical indication, I need to take this patient to the OR immediately within 6 hours to decrease the risk of mortality. So go quickly, see this patient's family, take consent, and advocate in the OR desk to book this patient as soon as possible and to prevent any delay. But sometimes you have no control over it. If they consult you, for example, after 6 hours, and the patient hemodynamically is unstable and you can't wait, you'll take this patient, but you're going to consent the family. This is a really high mortality. The operative mortality may reach up to 20 or 40%, given the timing of the surgery and the MI. Is it clear?
Yes.
Any other questions?
Mariam, can I ask you a question?
Of course.
This is Farid here. It's very interesting and very refreshing, really, to see the interaction. My question to you, is it permissible in the Canadian exam, during the exam, to say I will consult with my iPhone regarding the guidelines? There are so many guidelines and there are so many confusing recommendations here and there. Sometimes you're just overwhelmed and or confused, or maybe just say, I will ask my colleague or ask my senior or something like that.
Mm-hmm. No, it's not. And we did actually mention this, and their expectation for exam that to be aware about every guidelines. I know in the real practice that we have time to read, to check the guidelines, but not in the exam. It is the same same situation when you come across, for example, a CT scan or a difficult MRI that we can't interpret in the exam. In the real time, you would go to the radiologist. You're going to go down and read or ask him to read the imaging for you and to interpret it for you. In the exam, they would say no. Just like give me your impression and your diagnosis. But I totally understand, and I know, and the exam is different than the real practice.
Okay, thank you.
You're welcome. Any other questions? Okay, thank you very much. I know it was only two quick cases, but I didn't want to go through a technical perspective of the coronary bypass surgery, and I want to focus on the preoperative management and to guide you through how to triage these patients. Thank you very much, and I will see you next week.
Dr. Mariam?
Yes?
I don't have a question. I just want to say thank you. It was really refreshing sessions. Thank you so much. It was beneficial. يعطيك العافية.
Ayat?
Yeah, this is Ayat. Yeah.
Thank you very much, Ayat.
Thank you. Bye.